Welcome, everybody. Welcome to this session. And we'll get going very quickly. I'm Dave Snadden. I'm speaking to you from the Lheidli Territory. What we'll do this morning is, as you know, we will go into the presentations. If you want to ask questions, we can pop them on the chat, please, and Tracy will help me monitor them. And if we don't get around them all, we will also hand them on to the presenter later on so that they can connect with you as well. So let's get going as we're quite time constrained. I'd like to introduce Erin Carlson. Erin, it's delightful to see you. I know Erin from when she was a student at the Northern Medical Programme, and it's so nice to see you presenting here today. Over to you.
Thank you, David. Nice to see you as well. It's nice to see a familiar name. So welcome, everyone. I'll just get my screen, my presentation up. Do you want to give me a thumbs up if you see that?
That looks perfect.
Okay, great. So welcome everyone. Today I'll be delving into the often overlooked challenges faced by physicians and other healthcare provider parents in rural medicine. This issue isn't just about healthcare, it's about the well-being of our communities and the professionals who serve them. Issues that affect how we attract, keep, and support doctors and other healthcare providers. But before I start, I'd like to acknowledge that I am joining this presentation from the traditional, ancestral, and unceded shared territories of the Kwantlen, Matsqui, and Kutsi First Nations. It's home also to the Surrey Delta Métis Association, and it's in Langley. It's known as Langley, BC. So I'm excited to introduce the working group that did this project. It's called the Parenting in Practice Working Group. It's an initiative led by Dr. Charka Mahaswaran, and it's under the RCCBC. Our goal is not just to support physician parents, but to fundamentally integrate parenting and all the ways it affects our rural healthcare providers into the fabric of medical practice, normalizing the issues faced by these parents, especially in rural areas. So our main objective in this project was to hear directly from rural physicians and other healthcare workers, actually, who are parents or planning to become parents. We sought to understand their unique needs and the gaps and barriers they face in juggling and balancing their dual roles as healthcare providers and parents. To gain these insights, we employed a survey methodology that combined elements of both a community needs assessment and an ecological survey. And we wanted it to offer us a comprehensive view of the challenges at hand. So we used a combination of social media platforms, including our own Parenting in Practice group and on Facebook and other physician Facebook groups. We also added it to the RCCBC newsletter and emailed it out to many physicians, rural physicians, and got some other people around the province. Our survey reached a diverse group with a total of 58 respondents, including 52 rural physicians and some other healthcare professionals, including a couple of NPs and RNs and students. We wanted this diversity to provide us with a broad perspective on the issues at play in rural BC. The respondents were spread widely across British Columbia, as you can see, from the West Kootenay to the North Vancouver Island. This geographic diversity underscores the widespread nature of the challenges we're discussing today. It's not just in one key location. We found a standout issue from the survey. And that was the challenge of finding childcare in rural BC. for these physicians and healthcare workers. A significant number of respondents faced or anticipated facing difficulties in finding suitable childcare, which is a fundamental concern impacting their professional and personal lives, and whether they stay in communities and how long they stay there. There were a spectrum of challenges. The challenges don't stop at childcare, but respondents also highlighted issues like distance from family and cultural supports, educational limitations for their children, spouse employment challenges, and more, painting a picture of the multifaceted difficulties rural physicians face as parents. So this just gives you a bit more about the issues, and it really shows you how the lack of suitable and lack of just any childcare was really front and center in this that came up in this survey, the respondents. But there's other things, as we discussed earlier. Oops. So some personal insight to put this into perspective. Let me share a quote from a few of the physician parents who responded to our surveys. So not having our families here combined with lack of childcare, that matches our schedules as healthcare workers is challenging. When our kids get sick, one of us has to somehow cover an ER shift or cancel a day in clinic in order to care for them, since we don't have family around to help with this. Demands of the job mean I spend less time with my family than I would like. And my partner is a stay-at-home parent, which means things are looked after at home, but I often feel like I don't get to be part of family activities as much as I would like because there are not enough physicians in my community. So I think those personal accounts vividly illustrate the balancing act these professionals perform daily. They also illustrate just how much issues relating to parenting and practice affects how these providers practice, their capacity as physicians and healthcare providers, where they choose to practice, and how long they choose to stay at various rural communities. So in conclusion, while these issues pose significant challenges for rural physicians, they also present us with an opportunity to learn and improve. It's clear there's a need for more in-depth research and proactive initiatives to support these vital members of our healthcare team. More research may open up opportunities to try new things and better support recruitment and retention in rural BC. And that's it. I would love to hear any questions or points of discussion or interest in your ideas for where this could go. As researchers, I'd love to hear your ideas.
Thank you very much, Erin. This is such an important topic, and I'm certainly sure one that could do with a lot more kind of understanding and data behind it. I certainly really agree with you that in terms of recruitment and retention, that the kind of ecosystem of each community in terms of sports and spousal employment and childcare and all these things is so important in retention. If anyone has any questions, please put them in the chat box and we'll be able to read them out.
Well, I don't see anything in the chat box. I might just mention that ideas for further research. This was just an initial survey, and it showed such a dramatic concern around this issue that we've had discussions in and amongst our parenting and practice working group about opportunities to try pilot projects, for example, could be started. Things that have come up when our ideas are the potential for, similar to universities, they have childcare facilities sometimes that are high quality attached to universities. We've thought about, could this be a type of model that could be trialed in various communities? And so if anybody in this presentation listening would be interested in further exploring these issues, here's my contact information. I would love to hear from you. And I do have some space and time to potentially partner with somebody to do some more research on this.
So there's an invite for you all to help Erin take the next steps in what I think is a really, really important area for rural practice. Does anybody have any comments at all they want to put in the chat box? Also, Tracy, if people want to follow up with questions, is the best way just to go directly to Erin? Is that the best way to work the session?
Certainly. So you can correspond directly with Erin either through the chat or following the BC Rural Health Research Exchange. If you aren't quick enough to write down your information, that's just fine. You're welcome to email me directly. My name is all over everything you've received about the event, and I will be sending follow-up information, and I can put you in direct contact with Dr. Erin Carlson as well.
I see, Olivia, you have a question?
Yeah, thank you. I'd love to go back. I think you had, when you're talking about some of your participants, one of the quotes I think you kind of brushed over, or maybe I missed it, was something to the effect of, I would be practicing if the environment was more ideal. I'd love to know, is that something that, a theme that came through, or a thought for future research as well? Just
it's a thought that for future research, it wasn't a significant theme that we pulled out, but we do kind of, of course, you kind of wonder, could this kind of information be used to better recruit people? Because we know that so many, and most of the graduates from medical school are in child rearing age. So this is a huge, doesn't matter if you're female or male, this is a huge issue. It looks like Bob Woolard wants to ask a question.
Bring him on the screen, please.
Sorry, but I didn't want to cut that short, Olivia, but I think that, yeah, as we wait for Bob, I also wanted to mention that, I really think, oh, here, Bob's unmuted. Go ahead, Bob.
Oh, you're so very kind. I'm sorry to cut in. I was a rural doc for 2 decades and 16 years in Clearwater. And my wife, who has much more insight than I do, opined that we would not have stayed as long as we had if I didn't have such rich connections with the BCMA at the time, with the Canadian Medical Association, with colleagues outside of the community. And I just wonder what you're thinking and looking at in modern communication, where you don't have to, get guilty about your carbon footprint by being connected with colleagues around the country and around the province, but rather nurturing that kind of connection, both for the spouse and for the physician. Do you think there's a realm in that kind of connectivity that would be worth looking at?
It's a great question, and luckily, you're right. We do have some outreach with our Facebook group, and we're working on developing our next steps for creating virtual communities of parents in rural medicine to support. That's part of the support, and we've done some other initiatives too, but that is one of them for sure. Yeah. And
fantastic, and thanks for doing it in a thoughtful way. Not just meaning to do well, but assessing whether or not you're doing well. I just really congratulate you. Thank you.
We know that parenting does, for those who choose to and can and want to become parents, the learnings from becoming a parent can contribute a lot to our relationships with our patients and how we engage as healthcare providers too. So yeah, thank you, Bob.
Great. Thank you very much, Erin. We need to move on to our next presentation. It's been a very, very nice start for this session. And if anyone has any further questions for Erin or want to connect with her, you know how to do this. We will be putting these recordings out there for people to get hold of later on if necessary. And the next session is Sage Thomas, and it's also about parents. So we've got the first few are about this morning. So Sage, over to you.
Great, thank you so much. And yeah, this is very related to what Dr. Carlson just shared. So I appreciate your presentation as well. Can everyone see my screen? Thumbs up if it's all ready to go.
Looks great.
Okay, perfect. So hi, everybody. My name is Sage Thomas, and I'm an RN and a Master of Science in Nursing student at UBC Okanagan. And today I'll be sharing the preliminary findings from our study titled Understanding How Parents Build and Mobilize Personal Support Networks to Obtain Tangible Social Support in the BC Interior. And this study was supported by a SSHRC Partnership Engagement Grant, and we partnered with It Takes a Village, or ITAV Development Corp. They're a Kelowna-based company that designs digital tools to facilitate human connection. So I'm calling in from the traditional, ancestral, and unceded territory of the Syilx people in Kelowna, BC, where I am an uninvited and grateful guest. And the Syilx Okanagan People's Territory from Vernon to Penticton is also where we conducted this study. So to start, let's talk about parents and their support needs. Strong social support for parents of infants is critical to support parental mental health, and this can predict high-quality parent-child social interactions and child development outcomes. Social support can be informational, emotional, or practical. And practical support includes tangible hands-on support like providing help with meals, chores, or childcare. Parents of infants may not have strong, tangible support networks. And in this increasingly digital age, parents may use digital tools to meet their support needs. So parent experiences of accessing emotional and informational social support within digital and virtual systems have been relatively well described. However, there's a knowledge gap on how parents use digital tools to access tangible hands-on support. So to address this knowledge gap, our research aims were to describe parent experiences of accessing tangible social support while parenting infants under age 2, and describe the opportunities and challenges parents might experience using digital networks to access tangible support. So we explored these opportunities and challenges with participants by looking at a digital tool developed by ITAV called the Village app. So the Village app is a platform for people to build local personal support networks with their neighbors. And this is a qualitative study with the theoretical underpinnings of Bronfenbrenner's ecological systems theory and feminist and post-structuralist perspectives. So Bronfenbrenner's ecological systems theory guided us to consider how parent experiences are shaped by internal family factors and systems, and as well as how broader environmental factors and systems shape parent experiences. And then in addition, we integrated both feminist and post-structuralist perspectives to more richly consider the influence of gender and power relations in sharing nested environments and systems. We collected data through semi-structured interviews and focus groups, and we had 17 interviews with 2 focus groups, and we analyzed the data using reflexive thematic analysis. So using a purposive strategy, we recruited 26 community members in the Okanagan Valley, including parents of infants under 2 years of age, formal care providers, and community-based social service representatives who work with families. And we stratified recruitment across the Okanagan, including more rural communities such as Summerland. And of the participants, 26% of the parents identified with a non-dominant group, including ethnicity, disability, sexual orientation, religion, and race, and 2 parents preferred not to answer. So in terms of preliminary themes from the data, we developed 2 overarching themes, childcare and mental emotional support, and 3 sub-themes of experiences of trust, mistrust, inclusive accessibility, and societal expectations. And digital considerations were woven throughout the data and include opportunities for using digital tools to meet parents' practical support needs. childcare was identified by most parents and care providers as the most common and pressing practical support need. So, for example, we know a number of other parents who are still desperately searching for childcare in order to enable them to work. But we don't have childcare for a baby because it's not available. So that's a huge struggle for us. Anything that needs to be done with a kid in tow. I took my baby to the dentist for a cleaning, and I rocked her stroller with my foot while the hygienist cleaned my teeth last week, to give you an idea of where I'm at. And mental emotional support was identified as foundational for parents to care for their children, and childcare was identified as a practical way of supporting parent mental health. For example, having someone just come over and look after the child so you can have a shower or 5 minutes of peace, or to help with a screaming baby, or help with nap time if you're struggling. People with postpartum depression, I would assume, would need a lot more support. I certainly found that to be the case. And probably the foundation to everything is support for good mental health from others, because if that's not around and mothers are struggling, then everything else falls to the wayside. And the other important things don't happen, and a trip to the grocery store might not happen because things are just not functioning well. And mistrust was shared as one of the key barriers to accessing practical support, such as childcare, both in person and digitally. For example, I know a lot of people struggling with welcoming other people into their circle or their bubble, and huge trust needs to be established before you'll trust somebody with your children. And mom groups on Facebook are helpful, and some people do use some for last minutes if they need childcare, but that doesn't feel very safe. You don't have an existing relationship with someone. Various facets of inclusivity and accessibility influence parents' ability to engage with the practical supports, such as cultural, financial, or rural considerations. So there's nothing really in our neighborhood. It's a lot of acreages, a lot of vineyards, and kind of farmland, so that makes it hard. You don't really have any neighbors next to you that you can just go and knock on the door, or that you see with their kids in the backyard, so you can kind of make that connection. It's quite separated where I am. So I can definitely see that being an issue, and in that everyone is just so spread apart. And it's harder to access cultural sort of food or daycare related things in a smaller town. And was it harder to be a parent before or not? Like, now we're expected to work. Financially, we kind of have to, because as we all know, it's expensive to live in the Okanagan, which we've chose. But you kind of both have to work. And then once you have to go back to work, what are you doing about childcare, which we know is a big issue in the Okanagan? And some parents felt impacted by generational and other societal attitudes and expectations about what they should or should not be doing as a parent, impacting their ability to ask for practical support. I think the judgment as a parent, like, everyone feels like mom should be able to do everything. I definitely feel like generationally, my parents or my husband's parents and grandparents are like, oh, you should be able to figure it all out. And I think that stigma surrounding asking for help and being open to receiving it is still a bit awkward, and I guess embarrassing for some people, because they feel like, well, if I have to ask for help, that means that I can't do it on my own. And when thinking about using digital tools to access practical supports, parents and caregivers considered opportunities for using digital tools that related to the other themes. There are many opportunities for digital tools to support parents' practical needs, such as helping neighbors to connect in ways that feel safer to them, providing free or low-cost support, meeting other people with children of similar ages, or helping to shift the societal norms about asking for help. And one person said, maybe it could help you get to know your neighbors a little better. And in terms of implications for rural communities, some parents have inequitable access to practical support in smaller communities, and this presents a unique opportunity for healthcare providers and industry. Rural families may need more assertive or tailored supports, such as outreach to loop them into the community, especially if they're newcomer families, two-spirit LGBTQ, financially insecure, or living more remote. Creative options like cultural food choices and daycare such as halal, and efforts that focus on bringing people together in person for events to get to know their neighbors. So there were some limitations that link to the next steps. So the effectiveness of the app on building support networks is unknown. And this is a study opportunity to use a validated tool to measure whether perinatal support is impacted by the Village app or another digital tool. This is a local study and cannot be generalized. However, this is true, but it's not the point of this qualitative study. This study has increased our understanding of local Okanagan families' practical support experiences. And this study is not exclusively focused on rural parents, but looking at rural and remote parent experiences and the use of a digital tool would help us better understand if and how an app could help families meet their practical support needs in different rural contexts. Here are my references, and thank you. Does anybody have any questions?
Thanks very much, Sage, for a very nice presentation, and it complements Erin's very nicely. Does anybody have any questions for Sage? Please feel free to. Sage, did you give people a contact?
No, I haven't, but I can pop that in the chat as well.
And Tracy will also capture in case, you know what happens with chats, we tend to lose them. And I must say that as a senior with 3 grandchildren around the corner who are all now teenagers, we're still running them around a lot to support the family. And I think your idea of it is important to be able to ask for help is so true.
Yeah, thank you. Oh, I see a picture or a question here. What policies do we have for working parents and childcare in BC? That's a great question, and I don't know the answer to that one, unfortunately. And Bob.
Oh, I was just typing. It's a thank you to both you and Erin, and a wistful statement that I hope when you're my age, you don't have the regrets I have about the sacrifice that the families made.
Thank you for sharing that. Yeah, appreciate that.
Erin has also made a comment which is very useful. Do you want to say it verbally, Erin? I could get Tracy to unmute you.
I think because I'm technically a presenter, am I unmuted now?
Unmuted, yeah.
Okay. Yeah, I guess I was just saying if there's a platform that links people in more ways than just being some like mom groups, such as there's physician mom groups that I linked in with, and they were almost like the more and more specific they became, the more I could trust them. Did you find anything about that being helpful to build that trust in those groups or those online platforms?
Yeah, like parents did talk about how like if you're just in a massive Facebook group that's, you know, there's thousands of people or hundreds of people, it's this sort of tension between being anonymous but also being like hidden. And so yeah, there's not a lot of trust in that where you can just, if you're a single parent, reach out for help with childcare in a group like that unless you're super strapped. So yeah, the smaller that things get and the more relationship that you have within the smaller group, the safer it feels, which makes so much sense. And I think in the rural context, it's harder because there's also fewer people with shared experiences. So
in your location, yeah.
And I think exactly, and that's where if parents are left to reach out for that support on their own, they may not. So if the community notices that there's people that have moved there, you know, reaching out goes a long way because parents can have a lot of shame for asking for help. So that was one of the key things. And I hope that more research is looked at in rural communities around this because I think there's so many experiences we need to hear about to support parents and so that parents stay and work and live in these communities.
Sure. Thank you very much, Sage. We will Let's move on to the next presentation.
Thank you.
One of the things for all of you to remember, and it comes from Alba's question about policy, is that what you're doing is creating evidence and data. And that is what finally begins to inform and push forward policy. So this is important work. So if I could now pass on to Melba, floor is all yours. Thank you very much.
Thank you, Dr. David. And I'll share the presentation. Can you see the presentation, Dr. Snedden?
Yes, you can see it fine. And call me Dave. We're very informal around here.
Okay. Thank you. Welcome everyone to my presentation, and I like to just say I acknowledge Thompson River University Kamloops campus, situated on the traditional and unceded lands of Tecumseh within the Secwepemc Ulu, the traditional territory of the Secwepemc people. And today I'm going to present about the emotional health and cultural care of people living with breast cancer in British Columbia, a grant funded by the Health Research Cluster Fund and the Interior Health. I have presenters Michelle and Ashwin, and I'm not sure if they're able to join today because they are working and in school. So I'm going to take this presentation on their behalf. So approximately 28,600 women will receive a breast cancer diagnosis. And I'm just wondering if this is on SlideShare. Try to put it on SlideShare. I'm not sure if it's on SlideShare. And according to the research study that says 25% of all novel cancer cases are going to be among women in 2022, which constitutes nearly 14% of the female who have cancer-related deaths in 2022. So highlighting the global breast health statistics and the prevalence of disease it underscores in specific regions, breast cancer prevalence is around 25% in the non-Indigenous Canadians and 30% in East Asians and 32% in South Asian. So for the aim of this research study, it is to dwell into the psychological needs of immigrant women and explore their crucial role as they connect with healthcare providers to address the unmet needs when they are working through their own cancer journey, and also looking at areas that link to their own culture, language, and hindrances with access and utilization of healthcare in British Columbia. So one of the global and regional trends in breast cancer has been very prominently seen in the recent years with the changes that has happened with COVID-19. So the unique cultural beliefs and ethnic minorities of people who have migrated to Canada and their own needs for healthcare, health literacy, and that impact them when they are seeking healthcare, and also their own connections with the psychological well-being with breast cancer. So some of the research studies and the literature review point out due to lack of emotional care and communication barriers, lack of knowledge, and low health literacy, they find it difficult to navigate the healthcare services and to establish relationships and trust with healthcare providers that they're seeking care with. So the aim of this study is to examine the perspectives of immigrant people in meeting psychosocial needs and improving access to culturally appropriate care. So the research study was grounded and little emphasis was placed in the initial using a community participatory action research, where we initially used an environmental scan of the community resources in British Columbia with related to cancer services and community services to help and support people with cancer. A literature review on what is breast cancer, the meaning of that to immigrant people, and also survivorship, and how effective are peer support and mentor support groups in British Columbia, and connecting with the Community Advisory Committee. So we had engaged some community engagement workshops in the community and looking at cancer supportive care and what intervention protocols are very specific and required for people, and engaging with stakeholders, healthcare providers who care for people with cancer and their caregivers. So the end product of that was looking at validation and triangulation of the study findings, knowledge translation, and community engagement workshops that is concluded the whole research. So the main methodology used was a critical ethnography, a qualitative approach that utilizes in-depth interviews and to triangulate the different methods. And it was more appropriate to understand what mediators are helpful in emotional care, cultural care, and the psychosocial well-being of immigrant women with breast cancer in British Columbia, because it takes into account some holistic experiences. To enhance the study, we also had connected with stakeholders and non-profit organizations, BC Cancer, Interior Health, and breast cancer support groups in British Columbia, to look at recruitment and also to look at connecting with people who have cancer. So we had engaged 27 immigrants who had experienced breast cancer in Canada living in rural communities. And we had an ethics approved from Interior Health BC and Thompson River University to look at the quality of the study. The main results that came up from the study that was analyzed was related to the participants' own understanding of their cancer and meaningful and effectiveness of their own psychological well-being. So it alluded to one of the fact about lack of sufficient cancer care related knowledge, resorting for them to go through online research and facing challenges in accessing digital literacy and appropriate healthcare information. The second main theme that came up was highlighting the lack of emotional and psychological care and the increasing psychological and emotional distress they experience throughout their illness treatment and during recovery and survivorship. So speaking to the first theme that looked at the insight from their own cancer diagnosis, their treatment, and consulting with healthcare practitioners for the need to open up about their own distress and problems they face, and fostering that kind of trust with the healthcare providers. One of the things was on limited knowledge was information gap, where they spoke about limited education and information about their illness. And the second one was about their own relationship and trust with the family doctors and impact, where they identify that family doctors sometimes can play a key role during the diagnosis and treatment of the cancer journey and going back to the family physicians after the end of the care. The second main theme that came up from the study was experiencing the emotional and psychological distress from the treatment. So the health variability of the various distress they felt was impacting their own relationships with the healthcare providers and also in their own spheres of way they work and connect with their own day-to-day life. So they spoke about the distress and receiving cancer care treatment that actually negatively impacted them with their relationship with their family and friends because of the nature of the cancer and its stigma and the embarrassment of having cancer. And the second was about lack of cultural support and hesitating to identify themselves as a cancer survivor at their workplace or in a support group, or even avoiding support groups or social groups due to the stigma attached to cancer and negative associations with cancer and how cancer evolves during time in a person's life. The discussions from these findings spoke about the importance of culturally sensitive support, individualized approach, and also addressing the knowledge deficits of clients or patients who have had breast cancer. So one of the things that we looked at in discussing with our stakeholders and from the findings was how can healthcare providers develop more effective physical and psychological interventions for women with breast cancer, considering their own cultural experiences and background. One was looking at tailorized interventions, using an approach of cultural sensitivity and cultural competence, and using cultural assessment in their daily assessments with the clients, and use of language accessibility and inclusiveness of language and accessibility of language on digital platforms and printed books, connecting them with their own ethnic and cultural support groups with peer support and mentors, and having individualized care plans in their survivorship care plan. The second main challenge was about needs of breast care patients and also their immigrant background, and how to promote inclusiveness and participation for them in their own care when addressing their own knowledge deficit and language barriers. One of the main things that was looking at is culturally sensitive care tools and approaches to working with the people, use of multilingual resources and languages when using educational resources online and in printed form, and fact sheets, and use of more of patient education throughout in prevention and early diagnosis screening, and even during their treatment and post-recovery. So the knowledge translation that came up, the recommendations from the study was for healthcare providers to acknowledge and respect the cultural differences, beliefs, and values of people who go through the cancer, developing psychological, oncological standards of practice and competencies to ensure comprehensive, sensitive care, especially for psychosocial and emotional well-being, and expanding the healthcare availability in both rural and urban settings to guarantee equal equity to care for all women with the breast cancer. These are a few references that we used in the presentation, and our partnership with and collaboration with different associations and institutes in British Columbia, and our students who have worked with us, and a funding grant, NEEM, and no conflict to declare in this research study. So just like to conclude, if you like to connect with us, this is our connection here. And if you have any feedback and questions, you can always email us. This is our email here. Thank you very much for listening to the presentation.
Thank you very much, Melba. Another such an important topic for us. So it's great to see these important things coming through, and a very nice piece of research. So it also strikes me that so much of this is to do with relationships, and how good relationships with healthcare providers and patients has so much to do with their well-being. So it's nice to see that coming through in your data as well. So are there any questions for Melba? So none coming through so far. But you do have the details to connect with Melba if you have questions, or if you're interested. And what about the next steps? What's coming next is a question that's come through.
Okay, the next steps right now, we are having a grant from the Breast Cancer Society of Canada and from CHR that is looking at specific knowledge in interdisciplinary approaches to oncology with relation to cancer care education for breast cancer. So that way we are at is developing webinars, telephone support, and coordinated community resources in the community in British Columbia. That is where we are working right now.
That's fantastic. And thank you very much. This is such a good piece of work. And I'm sure that as you expand the cohort that you're working with, coming back to the rural communities, that you come to sessions like this might be a good way of expanding your research. But I don't see any other questions. Any other ones before we move on? Thank you so much, Melba, and nice work. And we look forward to seeing the next steps. So I'm going to move on now to Levi, who's just joined us now. Levi, please tell me if I'm pronouncing your name wrong. And you're going to talk to us about work that you're doing in the Community Hospital. Are you speaking to us from Africa? And you're still mute. There we are. We unmuted you and let you get going.
Oh, I think we've lost Levi. So I do know his connection has been spotty today. We were testing the connection earlier, so perhaps we'll give him another moment to log on.
Is he speaking to us from Africa?
I believe he may be. I do know he's calling internationally. So I'm going to try and pull him back up. Here we go. Levi, can you hear us now?
Can you unmute him, Tracy?
I have requested for him to unmute him.
Okay, I think yes.
Okay.
Well,
Mhm.
Okay, Levy, we can see you now and we can see your screen.
Yes, thank you very much. I had a problem with connection, but now it's okay. So good morning, everyone. But where I am is the evening. I'm in Burundi, and first of all, I would like to say sorry for my English because I'm not very used to talking English. Our main language is French, but I'm going to try my best to let you understand what I'm going to say. So my research is titled "The Evaluation of the Efficiency of the Operating Room at Kibuye Hope Hospital," which was a comparative and prospective study of 1,876 cases over a period of 6 months, that is to say from July to December, which is a research study I did in collaboration with Dr. Theodore John, who is a surgeon at Kibuye Hope Hospital. So the background, the operating room, as you know, is a critical part of hospital infrastructure and an important area of healthcare services worldwide. To have an OR which is well organized and more efficient, we tend to see more operations. But if we have an OR which is inefficient, we tend to see more delays and cancellation, which leads to frustrations of OR staff and also patients. So maximizing efficiency, it's something which is very beneficial for both the hospital and the patients. The main objective of our study was to evaluate and compare the efficiency of the OR at Kibuye Hope Hospital before and after the implementation of an incentivized protocol over a period of 6 months. We started this study July 4th and we ended this study December 13th of the last year. The specific objectives was, first of all, as I've mentioned, the evaluation, but to make first necessary to have measured variables. So we first set up new time registers that documented specific moments for each OR, that is to say, patients entry into OR, and start and end of anesthesia, start and end of operation, and patient exit out of OR. Here are the measured variables that we've set up. First of all, that was the start time of the first operation for each OR, the time between operations, that is to say turnover time, the percentage of occupancy and utilization of the OR during the day, Monday to Friday, the number and the percentage of canceled or postponed operations, and finally, the total number of operations. Secondly, we did a comparison. We did a comparison between what we measured and calculated with the desired data points to establish a design that we did during the first 3 months of the study. And we compared this with the result we found after the implementation of the new incentivized protocol, while continuing to measure the same data to allow for comparison. That we did this during the second 3 months of our study. For the methodology, as I've mentioned, we started this study. It was July 4th because July 1st to July 3rd, it was holidays, and that is why we started July 4th, but it was we had decided to start this July 1st, but I'm going to explain this after. So the location, it was the OT, the operating theater of the Kibuye Hope Hospital, which is a hospital, is an important hospital here in Burundi, in Central Africa, where we have more patients coming from DRC, also Burundi, and also Rwanda, and also Tanzania who come here to get operated because it's a hospital who have many surgeons who came from the United States, who came in a missionary mission, and that's why we have more patients. So the Kibuye Hope Hospital is located in the commune of Bukirasazi in the province of Kitega, which is located in the central region of Burundi. Our inclusion criteria was all patients who underwent scheduled surgery and in the operating theater at Kibuye Hope Hospital during weekday hours, that is to say Mondays to Fridays from 8 a.m. to 5 p.m. and were registered in the time register were all included. And all the patients operated on public holidays and nights were not included in our study. The materials we used to collect data, we used new time registers that I'm going to show you. I have an image, but I forgot to add it, but it has all measured variables that I said before. And also we've used NR case register, which already existing, which also still exists today. The OR case register, it registers all informations of the patients, how the operation went, the procedure we used, all the informations about the operation. And also, we also used, finally, we implemented the new protocol report. So the protocol I was saying was about 2 time measurables, namely the first patient's entry time into the OR and the average turnover time that we decided to incentivize with the targets as follows. We just mentioned that we will give 10,000 Burundian francs, that is about $3.5 to all OR staff if the first patient's entry time by 8 a.m. is superior or equal to 50% of the time, and that the average turnover time is inferior or equal to 25 minutes, sorry. And also we've mentioned that we could give 20K Burundian francs, which is almost $7 to all OR staff if the first patient's entry time by AM is superior or equal to 75% of the time, and that the average turnover time is inferior or equal to 20 minutes. So, ladies and gentlemen, it was a success with the implementation of the new protocol, but with the results, overall 1,876 cases were recorded in the operating theater, of which 979 cases, as I say, 52.2% were recorded during the first 3 months of the study, while the other 897 cases, as I say, 47.8% were recorded during the second 3 months of the study. But with the measured variables I mentioned, we've noticed a great increase or a great efficiency, which has been noticed after the implementation of the new protocol. Here you can see on this table that the percentage of on-time entry into the OR has increased of about 50%, which came from 60.4% to 66.8%. And also the turnover time increased of about 7% from 59.1% to 68.6%. And also the other measured variables had an increase, like the percent of on-time start of an operation, also the OR utilization during the day, but the percentage of cancellations and postponements was not really changed, but it was due to some reasons that I'm going to say in the next table. But here, with these results, we found it's like the same of results that Negash et al. Found in their studies. They made same studies in Ethiopia and Tanzania in 2022, and they found that it was really a good point to notice if we are going to make our protocols to see how we can increase the efficiency of the OR. That is also what Wright et al. Found in 2009 in Ethiopia. As I was mentioning about the cancellation and postponements that has not been changed, we have to see that many reasons of cancellations and postponements was first the lack of OR time. During the first 3 months, it was the lack of OR time, but it has decreased, but not really decreased, as we can see. But all others reasons of cancellations was patient-related factors like patient with active infection or patients with uncontrolled hypertension and so on. We also checked the complications, the postoperative complications and death globally, because we thought that if we tend to make an implementation and the OR staff is going to work harder and harder, maybe they could not get attention to what they're doing. So that we've also checked for the complications, and we found that there was not really a significant difference between the first 3 months of the study and also the second 3 months of the study. But also the thing that is more important here is that measuring the postoperative complications and death globally was really a good news for researchers of the area here in Africa, in Central Africa, because no one did do like a research about post-operative complications and deaths globally here in East Africa. So this is data or results that can be used for our researchers who would also try to do research about this. So about the conclusion of and also about this discussions a little bit. As the first study to our knowledge to examine our efficiency in Burundi, we were pleased to see objective improvement in our efficiency after the implementation of the new protocol. So the incentivization directly improved two targeted efficiency measurables, namely the on-time or intra and turnover times, and indirectly improved the other efficiency measurables such as on-time starts and or utilization of the day. And all these improvements occurred without negatively impacting the rates of cancellations and postponement, nor the rate of post-operative complications. And so thank you for attention. That is what I had to say. Thank you.
Levy, thank you very much for joining us, and what a fascinating study. I'm sure people will be interested to go back and look at your results, because we will post all the sessions. And it's so
Thank
much
you.
from where you are to join us here. Now, are there any questions? I see Bob's made a couple of comments in the chat box, but does anybody have questions for Levy before we move on to the next speaker? I think one of Bob's comments was it's very good that you looked at the possible harms, and that was very good. So has this encouraged you to continue with these new protocols? Because it looks like you're getting very good results.
Yes, we had recommended it to the hospital to continue to measure the efficiency of the RR here, because it is an important hospital and many patients are coming here, and there are some risks. There is a high risk that we could get more canceled or postponed operations that could lead to, as I've mentioned, to the frustration of patients, and also the frustration of the OR staff. But also there is that could also get the patients to spend more money to come, and also to notice that they are not going to be operated that day, and they're going to return home, and they're going to come back. And as you know, here the population has not very financial means to pay for the ticket to come, and also to come back home, and also to come back to the hospital. So that is something which is very important here, but also neglected, because here something which is, I can say, in our cultural Burundians, we don't give more importance to time. We think that if it's going to be done, it's going to be done whenever it will be possible to do. But time can be something which is crucial to the patients, because if you have you told them to come this day, and he came, and he did not notice that he's not going to be operated, there is something important which going to be changed for him, nor the financial means, but also his work, because most of them have children who are being I don't know the exact word I can say in English, but there's something which can be their schedule of their work, and also their time they are spending at home with their children is going to be very impacted. So that we did this recommendation to continue to measure the efficiency, but also to continue with this incentivized protocol to give money for to the OR staff to motivate them to continue. But unfortunately, I think that the hospital did not choose to continue with this incentivized protocol. Maybe they are going to manage this during the upcoming months or days. Yes, thank you.
Great. Thank you very much. Best of luck with the next steps. We're running short on time, so I'll need to move on to the next presentation, but I wish you all the best, and thank you for joining us. And we have your email if anybody wants to contact you or follow up.
Thank you very much.
So Sage, over to you. Levy, I think you need to undo your screen. There we go. Thanks.
Okay. I'll just jump right in here. Sorry, 1 second here. Hi, everybody again. Welcome. My name is Sage Thomas, and I'm an RN and a Master of Science in Nursing student at UBC Okanagan. It looks like my hand is raised. There we go. So today I'll be sharing the preliminary findings from my thesis work, the Nurture Study, the vital role of nurses for understanding and responding to the unique rural mental health and substance use experiences of children and youth. And I'm very thankful for the support of my thesis supervisor, Dr. Elizabeth Keys, and my supervisory committee, Dr. Nellie Olkey and Dennis Jasper. So it's important to acknowledge that I am an uninvited guest and am thankful to live on the unceded ancestral and traditional territory of the Syilx people. This study was conducted across BC on the lands of many different nations, and here's a website where you can check to see whose ancestral land you're living or working on in case you're not sure, and that's within Canada. So an estimated 10.8% of Canadian nurses work in rural or remote locations. These nurses work with people across the lifespan in community health, acute care, long-term care, outreach in people's homes and other settings. And these settings are more isolated from services and specialists with fewer resources compared to urban settings. And within Canada, an estimated 20% of the population is experiencing a mental health or substance use disorder in any 1 year, with children and youth significantly impacted. And to access MHSU care in rural communities, children and youth may face multiple barriers such as stigma, financial insecurity, lengthy wait lists, extensive travel, fragmented care, absent services, and so on. So in this context, nurses may be the first point of contact and a key professional support for rural children and youth, providing mental health and substance use care. However, there is little research exploring this practice area in community settings. And by better understanding and supporting the work that these nurses are doing, we can improve rural child and youth MHSU care. Therefore, the aim of my qualitative study is to answer the question, what can be learned from the experiences of nurses regarding the provision of rural child and youth MHSU care in community settings in BC? And to answer this research question, I'm conducting an interpretive descriptive study. So this qualitative methodology was developed within nursing to support applied and practice-oriented research aims. It's a theoretically flexible and pragmatic methodology, as long as there is a strong rationale for why the researcher is making the methodological decision they are making. And so far to collect data, I have spoken with rural nurse participants through 6 virtual semi-structured interviews, and recruitment is ongoing. The Knowing the Rural Community Nursing Framework was used to help create the interview guide, and this helped me to ask comprehensive and rural relevant questions. So this is a fairly new framework, and this has been an opportunity to try this framework out within research. To analyze the data, I'm using reflexive thematic analysis combined with interpretive description. Reflexive TA is a qualitative analysis method, and both value researcher reflexivity, context, theoretical flexibility, and are built upon or explicitly account for theory. Reflexive TA offers structured support for the analysis through these 6 steps, and interpretive description helps to orient the analysis towards what can be learned and what is useful for this clinical practice area. I'm using a purposive and snowball strategy to recruit study participants who are self-identified, rural or remote nurses of all nurse types who work with children or youth in community practice settings. Nurse practitioners and registered nurses were the only nurse types that responded to the study so far. For context, the nursing role that these 6 nurses described included rural and remote settings, which included hub and spoke centers with larger populations that service more remote regions, including Indigenous communities, and remote winter fly-in communities. The roles were multifaceted in community settings, with some roles including more informal MHSU care woven throughout primary care, formal care with direct care strategies such as suicide assessment and mental health treatment, And one nurse worked as a specialized addictions care nurse with youth. Most of the nurses worked either solo or on smaller teams, while some nurses worked in a larger interdisciplinary team. Some nurses described the unique context that rural children and youth are situated in, where, for example, they may only have a few peers their age and can be highly influenced by these peers for better or for worse. And similarly, in some of the smaller communities, youth may hold themselves at a higher or a lower standard of what they believe is possible for their lives due to how they are nested within their community. They may also be impacted by intergenerational trauma and may have fewer resources to draw upon for their well-being. The reality that everyone is related, so everyone is connected, came up in multiple interviews, and it's an important reminder as children or youth can be highly affected by what happens within their small communities, and they typically have less agency due to their age. So within this context, these nurses describe different strategies for working with children and youth, primarily youth, for MHSU care. These themes are caring like it matters, leveraging lived experience, creating spaces to be heard, and showing up in community. So the first theme is caring like it matters. Some rural nurses shared their relational care approaches, including building trust over time and using a flexible approach. Can we get you leaving here feeling a little bit better if you don't want to see mental health services? Do you want to come see me every week? Do you want me to call every day? It's really whatever people need, we try to make happen. And I think it's just walking alongside people in their lives. I mean, it's really nice when there's continuity of care up here, but that's a staffing issue. That's a big struggle in the rural communities, just having that continuity of care to kind of build that trust with teenagers. The second theme is leveraging lived experience. Most of the rural nurses expressed that their lived experience was important for child or youth MHSU care, whether it helped deepen their understanding, relate, or know how to provide care. And it helps that I had a background myself, being like a pretty troubled youth and more in that direction of like suicidal ideation, self-harm, and I got through it. So being able to share that with teens actually helps a lot to build rapport and also to know where they're coming from. I ended up with PTSD, so I do have that ability to help. I know my tools now that I use, and I've done a lot of education to help myself. And I use that to help other people of all ages and to help parents with support until they can see someone else. And then also being a mother, I'm able to help parents with those struggling teens. And I've had lived experience with mental health and addictions as a youth. So I think like having lived experience has helped me a lot just to understand better what needs to be addressed with the patients. For the third theme, creating spaces to be heard, some rural nurses created safer, confidential spaces for youth to talk about their struggles. Some youth may otherwise not have access to such a space in their community. You learn so much just in that hangout period. They like drop those little nuggets about what they're actually feeling. They need the space and time to do that. Youth who are just not coping well with whatever is going on in their family, they need someone that has nothing to do with their family. But it's really hard because there's no self-service here. And the only place the youth has like an ability to make a phone call is in their house, which is where they don't want to be and where they can't talk usually. And the fourth theme is showing up in community. Some nurses identified how broader and more visible community-based strategies may support youth mental health. So once a month, we have a fire and the community comes together, and it's a really great community support, really well received in the community. And this is regarding human rights protest. So there's a visible support, you know, like we as the providers go and we wear the t-shirts and show our faces and let the people take pictures of us and say who we are. And then that in hopes will trickle to the patients, especially the young folks, to know that their providers are safe. The beginning implications from this study are that rural and remote nurses are doing things that we may not think of as mental health or substance use care. Creative and heartfelt strategies that support children and youth, and this information is important to share and start discussing. I'm starting to create a nurture toolkit that shares the resources and strategies that some rural nurses use to support the mental health of children and youth. And for the study limitations, so far this study has a small sample size. However, It is an ongoing study, and I'm actively recruiting more rural BC participants. And number two, we do not know the impact of these strategies in rural communities. So a quantitative study measuring the impact of things such as leveraging lived experience on mental health outcomes of youth could be helpful. And this is a local study that cannot be generalized, but it does start to show us what we can learn from multiple nurses in a variety of rural and remote communities in BC. Here are some resources or references, and thank you. So I'm still looking to recruit 3 to 4 or more study participants, so please feel free to share this information widely. And in wrapping up, does anybody have any questions?
Thanks very much, Sage. What another important piece of research. And I really like the interpretive approach because it allows you to deal with the different contexts of the different communities. And that's such an important piece of rural research. So does anybody have questions for Sage? And
There are a couple questions and comments in the chat.
Okay, I see by Tracy. Thank you. So how do you see the preliminary findings or themes to move it forward? How do we learn more about your toolbox? Thank you. So that's very much in the works, but so far what I'm seeing is especially one of the findings that's come up in every interview around lived experience. I don't remember learning about leveraging my lived experience in nursing school, and I don't think that's widely taught. It may be, but it's something that I think most of us do, but there's resources around therapeutic self-disclosure. So what I would love is to kind of bring these stories into a toolkit so that we hear these nurses' experiences and voices, and then kind of nest that in some practical tools such as therapeutic self-disclosure resources and some research around like how to best use our lived experiences or how we could use it. So ranging from that to looking at provincial virtual resources that are available that a lot of people don't know about, like Compass Mental Health. Anybody in the province can access that and speak to a clinician for practice support. And, you know, most people know about the Race Line, but there's tools that nurses or other care providers may be able to access that they aren't aware of. So I'd like to have like a fairly comprehensive list ranging from like something you can really learn in the moment that you can do to reaching out and accessing locally or provincially. So it's still in the works. I'm hoping to interview 4 to 9 more nurses and then create that toolkit, share it back with them and share it more widely as well, and try to start that conversation.
Great. Thank you very much, Sage. And it's really nice to see a work in progress, and you can sense that people are really quite enthusiastic about what you're doing, and we would like to see where it ends up. It does strike me that like some or almost all the presentations this morning, the core of what these nurses you interviewed are doing is that building of relationships in rural communities. It's so critical. And in some ways, it seems to be the piece that's missing from much of the healthcare training these days. So best of luck. And if anyone has got nurse friends or the nurses here listening and they want to participate, please get hold of Sage. We need
Thank you so much.
More respondents. So we're 1 minute to the next session. I'm going to give you a 1 minute bio break, and we'll get going very, very quickly with our next person. And that's Joshua.
Perfect, folks. So 1 minute, Josh will be with you at 10:35.
That's great. So, Josh, welcome.
Hello.
I think we can get going again. You're also touching on such an important thing for rural residents in terms of emergency medical transport. So looking forward to hearing from you. Off you go.
Oh, I think maybe that's a different topic.
I'm looking to the left of your name rather than the right. I'm just totally confuse you. So yeah, you're looking at adolescent sexual health education in rural Nepal, something completely different.
Yeah.
Off you go.
Thank you. So hi, everybody. My name is Josh, and I'm a second-year medical student at the University of British Columbia and a part of the Nepal Sexual and Reproductive Health Project, which is a global health initiative at the University of British Columbia. And today I'm here to talk about enhancing adolescent sexual health education in rural Nepal, a collaborative approach, and the development of a training of trainers manual. I also want to start by just acknowledging that this project wouldn't be possible without the RGHPI grant from the Rural Coordination Center of British Columbia. I wanted to say thank you for that. I also wanted to start by acknowledging that I'm coming from the traditional, ancestral, and unceded territory of the Musqueam, Squamish, and Tsleil-Waututh people, and that we're coming from all over British Columbia today, and just to take a second to acknowledge the traditional care holders of the lands that you're on. And I have nothing to disclose. So our project takes place in the Dong region of Nepal, which is highlighted in red on the map. It's in the Tarai region, which is a flatlands along the southern border with India, and it's home to the indigenous Tharo people. The Tharo people are an indigenous group that have been isolated for many centuries due to a genetic resistance to malaria that was endemic in the region that prevented others from settling there. But in the 1950s, malaria was eradicated in this region, and settlers started to move in from other parts of Nepal. Once they were there, they established systems of bonded labor in which Tharo women and young girls were commonly sold by their parents into indentured servitude. This became illegal in the 2000s, but the practices have longstanding effects on women and children in the area, stopping them from getting sufficient educational opportunities and leading to a perpetual cycle of poverty. And this particularly affects young women and girls. So our partner in the region, Creating Possibilities, is a nonprofit in Nepal that works closely with the Tharo communities in Dang to provide educational opportunities for them. This involves delivering classes, creating scholarship programs, and building community centers and classrooms. The UBC Global Health Initiative has been partnered with them since 2015, starting a project focused on sickle cell disease screening and education. But in 2020, CP Nepal identified a new area of need that they wanted to work with the Global Health Initiative on, which was adolescent sexual and reproductive health. Although there is officially a sexual health education in the school curriculum in Nepal, there's a number of reasons why CP Nepal thought that the curriculum wasn't sufficient. They thought that the programs were poorly and inconsistently implemented. They thought that the curriculum was not comprehensive, and the access was especially low in rural areas like Dong, and not often culturally appropriate to the unique culture of the Tharo people there. So, together with CP Nepal and the Global Health Initiative, we created the Nepal Sexual and Reproductive Health Project. And our overarching goal was to address sexual and reproductive health barriers through empowering and educating adolescents in rural Nepal. We wanted to do this first by developing an in-depth understanding of sexual and reproductive health knowledge, attitudes, and services in the Dong region. And we were going to do this through literature review, community engagement, and a needs assessment survey of adolescents in the region. Specifically, we wanted to know what local adolescents' current knowledge and understanding was around sexual and reproductive health topics, and what topics that the youth in the community would like to learn more about. We wanted to identify barriers to accessing sexual and reproductive health services and education in Dong, as per what the community thought the barriers were. And we wanted to collaborate with local Nepalese organizations, especially organizations in Dong, to optimize services delivered to the Tharo communities. Then we wanted to take all this information that we gathered and create an educational adolescent health program that could be delivered by a local facilitator coming from the Dong region to facilitate this topic. And we wanted our program to be sustainable in the long term through developing a trainer of trainers manual, where local community health advocates could then teach other local community health advocates to deliver these programs in other regions as the program expanded. And we wanted to continually reevaluate and improve the program through this method. So we started by gaining some contextual insights, firstly by engaging with the local rural community. And one of the first places we went to were the mothers groups. These are groups of mothers in the community that get together to help each other. And when we started talking with them, they were very excited to hear about the potential for this project, and they wanted their daughters to take part in it. They talked with us about their shared experiences and challenges that they faced during puberty and the taboos around discussing sexual health that they wanted their daughters to better be able to talk about. It was especially important to have these moms on board because sexual health is such a taboo topic, and we knew that we needed that community involvement for the program to be successful. We then reached out to some other organizations in Nepal that were focused on sexual and reproductive health advocacy and education. And with them, we discussed gaps in the curriculum, and they shared with us their existing educational resources that could be a good foundation for an adolescent health program once it was adapted to the cultural context of the Tharo people. One specific organization that was important was YUA, who I'll talk a little bit more about in the next slide. Our literature review that we did highlighted that adolescents in Nepal are more vulnerable to gender inequality, child marriage, unwanted pregnancies, non-consensual sex, and domestic violence. And then we conducted a needs assessment surveying 100 adolescents from the ages of 12 to 18 in Dong, asking about self-rated knowledge on sexual and reproductive health topics, what topics they wanted to learn about, and the best ways to deliver a curriculum on sexual and reproductive health that allows them to feel comfortable and safe while learning about the topics. In summary, after all of this background knowledge, we found that sexual health education in schools currently was vague, age inappropriate, and did not meet the attitudinal and skills-based objectives that are outlined in the International Technical Guidance on Sexuality Education. These are international guidelines that are created by UNESCO and discuss all the important concepts that should be included in a comprehensive sexual health curriculum internationally. So, taking the YUA organization's curriculum from Nepal, we brought it to the Dong region by using all of the engagement with the community and our local facilitators to make it culturally relevant to the Dong context. We then started to deliver our Dong-based adolescent health program. It was delivered in small same-sex groups through a trained local facilitator named Sita that you can see in the bottom right there. And it included interactive activities and was offered outside school hours. The first sessions started taking place October 2021 with 3 groups of students in one community. Since then, the program has greatly expanded with many different rural communities and local governments reaching out to include this program in their areas, as well as for schools pushing for program expansion. And we now have over 747 girls who've gone through the program in 23 different groups in 3 different communities. And so as this program really started to expand and the need for it started to increase, we started thinking about developing this training of trainers manual so that we could hire more facilitators who could then start to teach other facilitators, and the program could be self-sustaining and spread on its own. So to develop this training of trainers manual, we took our current adolescent health program as adapted from the YUA resources with the engagement that we did with the cultural context in Dong. And we wanted to align it more closely with the international guidelines that UNESCO had put out. So to do this, we made sure that all 10 of our modules aligned with key concepts within these international guidelines, and that every point that we made within the modules themselves were aligned to learning objectives from those key concepts in the international guidelines. We then took the 10 sessions that we had and brought it to the community and the local educators and wanted to make sure that it was aligned with their cultural and community values. So we went through every session line by line to make sure that everything made sense, was aligned with the community, and would be helpful to the adolescents in the region. Since then, we've now implemented a few of the new programs using this training of trainers manual, and we have now 3 facilitators who are currently using this training of trainers manual to help run these sessions. And we have also started a pre and post program evaluation survey where the adolescents will fill out the survey before and after the program so we can get a better understanding of how the program is working for them and if it is truly aligned with their culture and community values. And this will be an iterative process that can happen again and again and again and be further refined to help suit the rural community needs. So this is what the training of trainers manual looks like. As you can see, we have 10 sessions based on the table of contents page on the left. And each session starts with a recommended schedule. So outlining all the different activities and sessions and how the session can look like. Every module has 2 or 3 key concepts based on these international guidelines and slightly adapted based on the appropriate level of education and comfort as determined by our local stakeholders, community engagement, and the local educators. So for example, here you can see that one key concept is self-care during menstruation. And one of the key learning objectives within that is menstruation usually requires some special care to keep your body clean and healthy during each cycle. And there's even further subheadings within that, such as define menstrual hygiene and explain its importance. So within each session, there's didactic teaching, there's activities to consolidate learning, and we also have game breaks to keep things interesting and allow the adolescents to move around. The Training of Trainers manual has diagrams, educator text, and activity descriptions to help point educators towards important information, give them tips on how to explain certain topics, and provide instruction on how to run the various activities. And at the end of each session, the key concepts are summarized in 1 to 2 sentences so that the educators know the take-home messages that they should focus on. There's also several different appendices in the sessions to give educators further information so that they can answer any potential questions that the students may have. And then just briefly, I'll mention that the survey that we're doing is specifically looking at the adolescents' knowledge around SRH topics, sexual and reproductive health topics, the self-esteem of the participants before and after the program, their gender equitable attitudes before and after the program, and their use of sexual and reproductive health services in their community before and after the program. And you can see this is just an example of some of the knowledge type questions we'd ask to see if they're learning some of the information that is in the sessions. And so as we continue with this, we are expanding the curriculum to include some new topics that CP and the community have been identifying as needs. This includes mental health, vaginal health, infertility, and prenatal care. We're also hoping to expand this session to include young boys. And we are continually updating the Trainer of Trainers manual to make sure it aligns with those community values and is really driven from the local needs of the people in Don. So these are my references, and I want to thank the Rural Coordination Center of British Columbia again, and of course, Creating Possibilities, who is an amazing partner to have in the region. And I will answer any questions.
Great. Thank you very much, Josh. What nice work. And there's 2 or 3 things that I noticed in here, which I think are important lessons for all of us doing research, no matter where it is. That you allowed, particularly rural research, you allowed the need to be identified locally. And you put a lot of work into community engagement, true community engagement, and cultural alignment. So congratulations on that. And
thank you.
We all look forward to seeing your evaluation results of this meeting next year.
Yes.
So Tracy's got a couple of questions here about, why do you think this has been successful, and has there been any resistance to the initiative?
So I think the success really comes from the adolescents themselves involved in the program. They have been amazing at really desiring this program in their region, and they will go and talk with all of their friends and tell them about it and convince them to try and advocate to their schools to bring this program to those regions. And so I think it spreads by word of mouth very quickly. And their desire for this education really is what's driving the community uptake, I think, as well as the mothers groups who are also really passionate about seeing this be brought to their communities. We haven't heard of any vocal resistance at the moment. There is sort of a subtle maybe hesitancy to bring in the program, but once the adolescents start talking about it and start advocating for it, it does usually seem that the schools are on board with it. So we haven't heard of any major resistance so far.
It's a great work, Josh, and thank you very much. Have you seen the note from Bob in the webinar chat about wanting to connect with you about the work he's doing with the university in Nepal?
Oh, yes, I will get in touch with you, Bob.
So any other questions for anybody, or if not, we will move on. And this time we're going to, thanks, Josh. All the best of luck in your studies. And as I say, let's see you next year. So Garth Lester is going to, we're now moving on to patient-oriented approach to understand the experiences of medical travel. Garth, this is such an important thing in rural BC, so we're looking forward to hearing from you. Off you go.
Thank you very much. Okay, pretty sure you can see my slides here. So sorry, just a second here. So my name is Garth Lester, and I am presenting the Rural Patient's Voice, a patient-oriented approach to understanding experiences of medical travel in Northwestern BC. You can see the list of other great people that were involved in this project. So very briefly, a bit about myself. I'm currently presenting to you from Vancouver on the Musqueam, Squamish, and Tsleil-Waututh Nation land. I'm born and raised in the small town of Smithers, which is on Wet'suwet'en Nation land, and I am an Anglo-Canadian settler. So as we all know, rural communities in Canada and BC have far less access to healthcare resources than urban areas do. As a result, medical travel has become a necessity in life for a variety of reasons. This might be for emergency services, for ambulatory care that's schedulable, or it might be for surgical interventions. What we know so far is that patients experience practical challenges, a variety of them, with medical travel, as well as some emotional challenges. We know that there are some resources that have been created to support patients in medical travel, and that it's not just patients, but also their family members that are impacted. The current literature that exists right now largely comes out of Australia, the United States, and a bit out of some other Canadian provinces. Often the research is focused on specific patient populations like children or patients receiving cancer treatment. There's quite a bit of quantitative studies, or there's studies focused on healthcare providers. And so the need that we wanted to fill the gap was looking at rural BC and looking at the general population, looking at both patients receiving emergency care as well as the schedulable medical care. So in general, the goal of our presentation was to understand patient experiences of medical travel from rural areas to urban centers. Specifically, we wanted to identify challenges and barriers from the patient narratives that we were hearing, as well as to elicit recommendations from them in a very patient-centered approach. Our study has a very specific focus in Northwestern BC, but it can certainly be generalized across the province and across the country. So this specific study is a component of a larger research project that's ongoing, and it's partnered with a group called the Northern Patient Travel Improvement Committee. And what they are is a group of patient partners, health policymakers, health researchers, healthcare providers, and Indigenous community representatives who help guide the research so that we can continue to ask relevant questions and know what is most important to the community. This study was a qualitative study that involved 14 patients and or family members when collateral histories were helpful, and they were interviewed in a semi-structured format. Once the interviews were transcribed, they underwent thematic analysis so we could pull out the common threads as well as some key recommendations that came out. And then for each of the patients, we did what's called a patient journey map, and I'll show you what that looks like in just a moment. So what were the broad themes? In general, we could see that medical travel has an impact in three major ways. Firstly is the major ways that it impacts patients. Despite the fact that there is financial support available for patients, basically every single story that we heard involved some level of financial impact that the patient experienced themselves. There's a lot of direct and indirect costs to medical travel. Secondly was the challenges around travel logistics, especially when it wasn't an emergency medical travel. Patients were often responsible for booking the flights, booking accommodation, and all that involves. And as well as it's important to note that even in emergency, that there's often travel logistics that are challenging. Patients often also experience challenging experiences when they traveled into the urban environment and experiencing that being quite different from their rural hospital care, as well as significant emotional and psychological impacts on the patients, just even through the medical travel, not necessarily just through the actual care that they received in the urban area. Major theme that was very clear in the stories that we heard was that there was an impact not just on the patient, but in very similar ways impacted the family. So there was a financial impact on the family. Family members are often traveling to support the patients either throughout the entire time or going to visit the patient. And so all the complexity that medical travel brings with it is not just on the patient, but also on their caregivers and those that are important to them. And unsurprisingly, as a result of that, there were psychological and emotional impacts on family members. Thirdly, what we heard was that there was an impact on the care that the patients were actually receiving as a result of the medical travel. For example, many patients were very aware of geographic health inequities that they experienced. For example, significant differences in the resources available between the rural and urban environments. There were a couple patients that actually expressed a concern that when they returned to a rural environment, that they wouldn't actually be receiving proper care because they weren't sure if there was specialized enough care for them. As well as patients felt that there was a difference in the availability of specialized care to them, even with medical travel options. Another important theme that we saw was that there were gaps in communication at key transitions of care, especially when moving from rural to urban or urban to rural, that communication to the patient or between healthcare providers was often lacking, and that resulted in delay of care or limitations of care. So as promised, this is what a patient journey map looks like. Patient names and community names have been changed, obviously, for confidentiality. This is basically just a story arc of what patients go through. And so as they travel from rural to urban, we crafted it into a visual representation so that we could capture their experience. An important component of it was that we didn't just capture the practical, logistical aspects of their travel, but also the emotional and the psychological impact, because that was very clearly a significant part of medical travel to the patients. And then for each patient, we also drew out the specific themes and positive experiences that we could look at. So this is just an example, kind of a prototypical patient who experiences medical travel. So this person, we'll call her Jaylene. She traveled to get endoscopy procedure, and she had to wait a bit before her appointments, and then that appointment was canceled or was delayed. So she had to book all the travel arrangements, and then cancel all the travel arrangements, and then book again. And then she traveled 1 hour by car, 7-hour ferry, stayed in an urban environment for a couple days, got the care she needed, and then traveled back, 7-hour ferry, 1 hour drive to get home, and then was able to be doing follow-up virtual as well as with her family doctor. So when we talk to our patients and their family members, there were 4 major ways that they recommended that there could be improvements. Firstly is the increase in financial support. There are a number of resources available to make it more accessible, but this was clear it wasn't enough. There was an increase. We want an increase in the amount of coverage that can offset the direct and indirect costs that patients are experiencing. Especially in the last couple of years with inflation, there's a big need to reassess how much money patients are actually able to access. There also needs to be a decrease in the delays and disruptions of appointments. Appointment cancellations have a really big impact on rural patients because of the complexity of medical travel. They often experience needing to travel multiple times for specialists, especially if they have complex needs. So a practical way would be creating some type of flexibility that allows for the scheduling of multiple visits into one trip, even if they're with different specialists, so that medical travel doesn't have to happen as frequently as it does. There also hopefully can be a way to prioritize patient context when a decision is made about who's getting postponed or delayed in their appointment, because it does have a larger disruption on rural patients than on urban. Thirdly, there is a need to improve the communication between healthcare providers. Urban and rural healthcare providers both need to be responsible for ensuring the continuity of care as the patient travels to and from, and we saw a number of cases of gaps there. There needs to be a more efficient way of sharing patient information to make it effective in order to continue the care back and forth. And finally, there needs to be a way to ensure that family support is provided and or culturally safe care is given. The family and caregivers were very clearly a significant benefit to the patient experience in medical travel. And so when we look at things like financial support or other supports, it's really important to make sure that caregivers can travel with their patients and that that can be an important resource for them, no matter the barriers. There needs to be a way of continuing to train and further train urban healthcare providers for cultural awareness to consider the rural context of the patients that they're seeing, particularly considering the Indigenous rural context of some of the patients they're seeing. And finally, an example that might be useful is for patients that are vulnerable who are in an urban environment and don't have family or caregivers with them, figuring out what resources can be available to help this patient navigate the urban environment so they don't feel so alone. A number of people to thank, particularly thanking the participants and families that were involved and the funding that we received. The remaining time, I'll open it up to questions.
Great, thank you very much, Garth. What a really important topic. That looks like Hudson's Bay Mountain, is it? And one thing that struck me is the data you're gathering. Is this going to the Rural Coordination Centre's Rural Transport Initiative? Because it would be important background data for them as well.
That is, so a big major part of this research was making sure that we could now back up what we're saying. And the goal definitely is to have conversations with people who are already heavily involved in medical travel. Yes, no, you're absolutely right. And that is one of the people that we are planning to discuss things with.
I think they would really appreciate seeing the kind of work you've been doing. Are there any questions for Garth? Where do you see your research going next?
So a major part of this is into the advocacy side of things. The other research that was similar that was just completed was actually talking to healthcare providers about medical travel for their patients. And so now that we've heard from both of them, the hope is to be able to look into what does this practically look like, possibly looking at some specific initiatives that come out of like Australia or some other provinces that have been effective, and look at how we could potentially promote those or advocate for those. There's both like the individual side of things. For example, how do we make individual physicians more aware of these issues, but then more system level where, you know, increasing funding is like a policy decision. And so looking at different avenues that we can promote change. Just see the question from Tracy about the journey maps. Is this something you think can be used to prepare others for their journey or in training for urban centers and teams? Definitely, we wanted to create it. The reason we created it was twofold. One was it's just a really good way of capturing patient stories for people who aren't familiar with medical travel. And so we wanted it to be a tool for training in urban centers and teams. The other component was just to show to the rural patients who participated, hey, this is what we got from you. This is our understanding of your story. Thank you. As well as helping us make sure we're on the same page. In terms of preparing others, unfortunately, some of the experiences were quite negative. And so I don't know if it would, I guess there's lessons to be learned, but for resources that would be helpful, one of the research assistants who preceded me, she actually compiled a list of all the resources that are available for both like housing, accommodation, and all this. And with the goal that hopefully this can be more easily distributed, because I think a lot of patients, unfortunately, aren't aware of what they do have access to. And hopefully with those type of resources, then things will be easier for them. That's a good question.
Thank you very much, Garth. And one of the important bits in your presentation is how you're trying to educate the people in the urban areas. And that's a critical piece of raising awareness there. And, you know, having dealt with a relative having a post-operative hemorrhage in Vancouver in a hotel room, and thinking, how would they deal with it if they didn't have a health professional nearby that could give them some help? And there are all sorts of stories like that from the patients. So best of luck with this, and we look forward to the next steps. And I'm sure the Rural Transport Initiative at the RCCBC, the group working on that, would be really interested to hear from you. So thank you, and we will now move on to the next presentation. And this would be Sharif Seaton. Have I pronounced your name properly?
Yes, you have. Thank you.
So over to you, and you're going to be talking to us about attached and unattached rural residents, and that's another such an important issue in rural areas.
Absolutely. Thank you for having me. So I trust you can see my screen. Perfect. I'd like to start by respectfully acknowledging that I live and work remotely from Prince George in the unceded traditional territory of the Lheidli T'enneh First Nation peoples. I'm a research coordinator at the University of British Columbia Okanagan campus, and I've worked on several projects in the School of Nursing since 2013. One of these projects, led by Dr. Kathy Rush, and my fellow research coordinator and now PhD student, Lindsay Burton, involves exploring differences in preventive care among attached and unattached rural living adults. So I'd like to tell you more about that study today. So as an overview, I will start with a brief project background, describe the methods, a few preliminary results, conclusion, current work, and then there'll be time for some questions. So first, as a background, we defined unattachment as being without a local primary care provider. And it's worth noting that there's a lot of gray in that area. It's a little bit more than just attached and unattached, but we won't have time to get into all of that today. But there are differing definitions of attachment in terms of whether people have regular primary care or a location for regular primary care. But we did go with the definition of having a local primary care provider. In 2019, Statistics Canada reported that 14.5% of Canadians were without a primary care provider, and that statistic was a little worse in British Columbia, with about 17.7% being without a primary care provider. And there's some evidence that that's worsened since 2019, but the new numbers, at least from Statistics Canada, aren't out yet. Provider shortages are particularly relevant to rural living Canadians, and I'm sure I don't have to make that argument to anyone on this call here. But unattachment can lead to unmet healthcare needs, given this gatekeeping nature of the Canadian healthcare system. And although we found there was not a lot of data directly comparing rural and attached to unattached patients in terms of access and use of preventive care services in particular. So by preventive care, we mean services such as immunization or cancer screenings that are offered to the general population, asymptomatic population, based on age and sex and risk factors for disease. So the goal of such services, of course, have been to prevent disease, avert disease, and ensure timely diagnosis and management when disease is detected, reducing the need for aggressive interventions and associated healthcare costs. So our goal was to explore differences in preventive care uptake between both attached and unattached rural patients, look at things like how much preventive care is being done, and what are preventive care priorities among this population. In terms of the methods, our recruitment involved primarily social media, community Facebook pages. We've had a lot of success advertising surveys on rural community Facebook pages. They're often a location where people go and look for local information in their community, and we've been welcomed in many pages to post our surveys. Rural newsletters are another avenue that we used, Reach BC and the Patient Voices Network. Data collection, again, involved an online cross-sectional survey. And analysis was primarily descriptive analysis, but also looking at group differences based on attachment. In total, 516 rural participants responded to our survey. This included 302 attached patients and 214 who were unattached to a local primary care provider. The average age was 51 years and ranged from 19 to 86 years, so we had a good range of ages in our sample. 92% of the sample self-identified as white and 74% as female, so this was a biased sample. So in terms of where patients seek care, just looking at attached compared to unattached here, compared to 83% of attached patients, only 10% of unattached patients sought care with a regular provider. And this was either by traveling or via virtual appointment, as these were providers in former communities most of the time, as the patient had moved to a new rural community and had stayed connected to a provider in a former community, often at great distances away. Instead, attached patients had much higher use of the emergency departments. Here you can see 21% versus 9%, higher use of virtual care modalities, and higher use of walk-in clinics compared to the attached patients. Notably, unattached patients were more likely to simply not seek care, despite having similar overall health and overall healthcare needs as the attached patients. And just to note, these percentages total more than 100 because participants could select all that apply, like where all do you seek care. In terms of prevention activity completion, unattached patients were up to date on 50% of their preventive care activities. And so, like I said, these included things like immunizations, tetanus shot, flu vaccine, screenings. We had 18 different preventive care activities, and on average, they were up to date on 50% of them. And that compared to 63% of attached patients being up to date on 63% of their preventive activities. There were no differences in the number of preventive priorities or the proportion of attached versus unattached who were unattached on individual prevention activities, such as blood pressure check, blood cholesterol screening. So the proportion who prioritized these individual activities did not differ between attached and unattached. So they saw them as equally important. In the open-ended responses, it was evident across both attached and unattached participants that there were more similarities than differences related to how provider shortages are being felt in rural communities. So here's an example of an attached patient saying, "I've given up on finding a doctor or ever even using a hospital unless it's life or death." And an attached patient saying, "I still have a family doctor, but I'm concerned about the near future because 3 of 6 doctors in our clinic are within 3 years of retirement." And many of the open-ended responses from attached patients also spoke to feeling those provider shortages in terms of the time it takes to get an appointment, the availability of care, even though they felt very lucky to have a primary care provider available to them. A common overarching theme was kind of this precarious nature of healthcare. Though many attached patients were grateful to have healthcare providers, imminent retirements and fear of losing local providers with no identified replacements were common themes. So in conclusion, we've really identified gaps in rural patients' preventive care that highlight the need for innovative solutions, maybe for both attached and unattached patients. Some have suggested that virtual or technological solutions hold potential for empowering rural patients to access preventive care. And so that takes us to our next steps. Although rural community members have told us that connectivity challenges and limit such technological solutions, the province of British Columbia has committed to providing high-speed broadband to all British Columbians by 2027. So we want to hear from members of rural communities at different stages of arrival of this service. So one of our current projects is focused on rural digital engagement and access. And all rural living BC adults are invited to complete our 15-minute online survey on internet-based access and use. That's what we're collecting right now. And paper copies are also available if you'd like to reach out and be sent a paper copy or paper copies to deliver or distribute in your community. So you can scan the QR code on the slide or go to our shortened URL here, bit.ly rural digital readiness to find that survey. So thank you all for listening, and thank you to the Rural Coordination Center for coordinating this event, a little bit more about our research team, and I'd be happy to answer any questions anybody has.
Thank you very much, Cherise. Very nice research, and it struck me in the last bit of where you're going next that there is a digital divide, and particularly, for some of our older population have got no idea how to use a phone or a computer. And we have to think about that too.
Absolutely.
So are there any questions for Cherise from the audience? So seeing none so far. Cherise, thank you very much. We really look forward to seeing the next steps in this. And we will now move on to our next presenter, who is Gia, who's going to be looking at the evidence for medication abortion in rural and remote areas. Thank you very much.
Great. Sorry, Dave, I actually do have one question and we have a couple minutes if that's okay.
Go ahead. I didn't see you.
Well, that's okay. I just added it. Therese, I'm just curious, how have the surveys been distributed so far? And how will they be, other than folks going directly to your site to access them?
Oh, for the Rural Digital Readiness project we're
Yes.
running right now. Yes, it's primarily an online survey. We've just launched it. I should have also acknowledged thank you to the BC Rural Health Network for putting it in their newsletters. So again, we're trying to use those local community social media pages. We're particularly targeting communities where the internet broadband speed is lower, but is supposed to be getting improved, right? We have this promise to have it come through by 2027. Our survey doesn't require high broadband width to access. And so we're really hoping, and we have been successful in getting a lot of people able to get through our survey, you know, without having significant problems. It doesn't require video or anything like that, of course. But we are also looking at distributing some paper surveys in the new year. Certainly willing to mail paper surveys to anybody who are needing them for sure. And yeah, through rural networks and Facebook groups. And so trying to use a bit of a snowball method too to reach some people who might not have access, because that's sort of the purpose, right? We want people of all levels of arrival, so people with and without access, but we really want to make sure that we reach that group that has lower levels of access to that high speed. Does that answer your question? Is that where you were?
It does. Thank you. Yeah. So through it sounds like BC Rural Health Research Network. I think I got that wrong, but I know it was in your slides. And yeah, maybe we can connect after. We may be able to, maybe I can help you pass that along to some of our connections too through RCCBC and communities.
That would be great. Thank you so much.
You bet. Thank you.
Thanks for having
me. Networks. Tracy will be able to help you with those, and using the BC Rural Health Network is a very smart idea because they've got very broad reach into the communities. Okay, anything else? So hearing none, let's move on. Gia, the floor is all yours.
Okay, great, thanks. I'm just gonna share my screen here. So can everyone see that?
We can, that looks great.
Okay, amazing. So hi everyone, my name is Jennifer and I'm a second year medical student at the University of British Columbia and a student researcher working with the CARTGRAPH Research Network. And I'll be talking today about two reviews that are part of a larger plan study called How Far is Too Far? And so before we begin, I'd just like to acknowledge that this work was completed on the traditional, ancestral, and unceded lands of the Musqueam, Squamish, and Tsleil-Waututh peoples. And it's important for us to recognize the ongoing impacts of colonization and subsequently strengthen our commitment to end these systems of violence and oppression. So difficulties accessing abortion in rural and remote areas are reported by several high-income countries where abortion is legal, including Canada. And in Canada specifically, about 18% of the population lives in a rural or remote community. And the map that we have displayed on the slide here shows the population densities of Canada and the UK in different shades of orange. And where hospitals are is represented by the blue dots. And so as we can see, there's a lot of geographical surface area that is far from hospitals in Canada especially, though can also be seen in Scotland. So early medication abortion services can offer a potential solution to rural-urban abortion disparities by bringing abortion care closer to home. And we see a need among those in rural and remote areas to have access closer to home so that they can avoid travel to an urban center for abortion, where they might need to leave behind family and work and experience significant expenses and disruptions. So medication abortion using mifepristone and misoprostol in the first trimester is highly safe and effective, though package labeling in Canada currently restricts the use to those with access to emergency services for 14 days. And abortion providers throughout Canada tend to interpret the risks and the guidance differently and may propose a wide variation in advice, ranging from a requirement to stay in an urban area for 2 weeks or 2 days, or to only have a procedural abortion option if they're living further away. There are also providers who are willing to prescribe despite the lack of clear guidance provided by these guidelines. And so the rare need for a transfusion after medication abortion seems to be driving the recommendation for proximity to emergency care, though currently patients and healthcare providers do not have accurate, safe parameters for care. And people may be required to either undertake unnecessary risks or unnecessary travel to access abortion. And so we set out to examine current global guidelines and available evidence on the need to be close to emergency services after medication abortion in the first trimester. And we undertook 2 reviews, a scoping review on how distance to care is characterized in current clinical practice guidelines for first trimester medication abortion, and a systematic review on transfusions following first trimester medication abortion. And both reviews focused on settings comparable to the Canadian context. And so we looked at guidelines and papers that were conducted in high-income countries where first trimester mifepristone misoprostol medication abortion is legal. And so first, I'll be discussing the scoping review on distance to care in current clinical practice guidelines on first trimester medication abortion. So we undertook this review to answer the question, how is the need for proximity to emergency services following first trimester medication abortion in high-income countries defined in clinical practice guidelines or drug regulations? And so we conducted the scoping review in accordance with the Joanna Briggs Institute methodology for scoping reviews, and our protocol is available on OSF. We searched Medline, Embase, Web of Science, and Google Scholar systematically, including hand searches of citations of relevant articles. And we surveyed gray literature, including country-specific clinical practice guidelines and mifepristone drug monographs. And guidelines were included if they were for a high-income country where abortion is legal upon request, as defined by the WHO Global Abortion Policy Database. And they were excluded if they did not provide guidance on mifepristone misoprostol first trimester medication abortion. Data was evaluated quantitatively to identify what proportion of guidelines mention access to emergency services, and qualitatively to capture protocol details, such as the specific distance to services and the duration that the access is needed for. And so title abstract screening was completed for 5,328 references. 167 full texts were assessed for eligibility, with 61 included in the final data extraction. And among the final guidelines and product monographs, there was guidance for 29 countries and 6 international guidelines. And every represented country mentioned the need to access emergency services in one of their documents, except for Lithuania. And in terms of the total guidelines, 11 guidelines contained no mentions of access to emergency services. 50 guidelines mentioned access to emergency services, but only 23 stated how long the access is needed for. The requirements for maintaining access to services ranged from a few hours or passage of products of conception to 2 weeks to always. And among guidelines that stated precise distance to emergency services, it generally ranged from a distance of 1 to 2 hours. And 5 guidelines required hospitalization beginning at least from misoprostol administration until the passage of products of conception for some gestational ages. We also found a general emphasis on the prescriber to provide patient instructions for emergency management, and or that the prescriber must be capable of providing emergency services. So our study is limited to high resource settings where abortion is legal on demand, and our results might not reflect conditions where abortion is illegal or those for low resource settings. And clinical practice guidelines and mifepristone product monographs for first trimester MA in high-income countries are inconsistent from each other on the need to be close to emergency services. And over half of the guidelines we reviewed did not state how long proximity to emergency services is required for, and requirements varied greatly amongst the guidelines that did. The exact distance is also not well characterized. And inconsistencies between guidelines may be due to a lack of data on rare adverse outcomes that require access to care. So this highlights a need for further research on this and linked risk factors to better evidence guidelines so that providers can serve individuals living far from emergency services. And so thus we also conducted a systematic review looking at transfusion following first trimester medication abortion. So currently the risk factors and the timing post-abortion for transfusions are not known, and our objective objective was to evaluate the incidence and the evidence for risk factors related to blood transfusion following mifepristone and misoprostol-induced legal first trimester medication abortion in high-income countries. So we conducted a systematic review following PRISMA guidelines, including original clinical studies reporting transfusion after legal first trimester medication abortion in a high-income country. We searched Medline, Embase, Web of Science, and Google Scholar systematically, including studies of all languages and of any year as long as abortion was legal. We conducted our search on April 7th, 2023, and our protocol is registered on Prospero. So 950 studies were assessed at title abstract level screening, and 121 full texts were assessed for eligibility, with 58 studies included in the data extraction. We extracted data on the overall incidence of transfusion, the risk factors or interim predictive clinical signs and symptoms, such as the mifepristone and misoprostol regimen, the weeks of gestation, the symptoms pre-transfusion and maternal demographics, and the time post-medication abortion to transfusion. So in our meta-analysis, we looked at the incidence of transfusion for different misoprostol and mifepristone dosages, simultaneous mifepristone and misoprostol administration, weeks of gestation above or below 9 weeks, and the overall incidence rate. And the figure here shows the number of transfusions per 10,000 medication abortions. And for each row, both mifepristone and misoprostol was administered in the first trimester, but they differ depending on the exact dose of mifepristone or misoprostol administered and on the timing. Overall, transfusion following medication abortion is a very rare event, and we saw similar incidences following different protocols, with incidences very close or overlapping for most categories. And there appeared to be a slightly lower risk for transfusion following medication abortion when the weeks of gestation was less than or equal to 9 weeks, and when additional doses of misoprostol were offered. In terms of any other risk factors, predictive clinical signs and symptoms, and timing post-medication abortion for transfusion, so for things such as maternal demographics, we found there was insufficient data in the literature to characterize. And so our limitations were that we only included studies reporting at least one transfusion, and further, many studies had subgroups within them, such as subgroups with different protocols, but they did not specify which subgroup or demographic characteristics were associated with the transfusion cases. We also excluded any studies that potentially reported on the same subjects as another included study. And finally, our results might not reflect conditions where abortion is illegal or occurring in low resource settings. So overall, first trimester medication abortion carries a very low risk of transfusion, and the lowest risk is probably among gestations under 9 weeks and protocols offering optional additional doses of misoprostol. And the risk factors and timing for transfusion after first trimester medication abortion are currently unknown. And so CART is planning a future research project called How Far is Too Far to find the evidence that we're currently lacking. And we plan to investigate the experiences of people in remote communities in accessing abortion and the perspectives, approaches, and experiences of healthcare providers providing abortion care for these communities through qualitative interviews. And we're also planning on investigating the incidence, urgency, and risk factors for post-medication abortion hemorrhage requiring blood transfusion, including the proportion of transfusions that are emergent or life-saving versus those that are not. And we plan to do so through population-based administrative data and clinical chart data. So here is my contact info in case you're a clinician offering medication abortion in a rural community who might be interested in participating in future research, or if you have any questions that you would prefer to discuss offline. But at this point, I would welcome any questions from the audience, if there are any.
That's great. Thank you, Jennifer. Very nice work and very well presented. Well done. It strikes me that once again, here's an example of where evidence creating guidelines in an urban setting just do not translate to rural areas. And I think you've identified that very nicely. So the next steps about how to, the systematic review that you've done, particularly the second one, there are a huge amount of work, these reviews. So congratulations on that. But you're also identifying how the risk can be minimized. So that's very helpful as well. And, you know, having been a practitioner in the Highlands of Scotland and dealt with a lot of these things there, it doesn't really translate to Canada. The distances here are so much bigger. So any questions for Jennifer? If any of you are interested in being part of the study, she is looking for people to join it. So if anyone's interested in that. Good. So well, thank you very much, Jennifer. Thanks for coming. And as I say, very, very good piece of research and very important for rural areas, and keep up the good work. So we will now move on, and we're moving on to Natasha and Olivia, who are, I'm very interested in this one, because you're working with artificial intelligence, which is a mystery to me. So
okay, I'm just gonna get our PowerPoint going. And okay, and you guys can see the PowerPoint okay there? Perfect.
All right, everybody, thanks so much. My name is Olivia Gomes Van Brolo, and I'm here alongside my colleague, Natasha Wood. We're here on behalf of a research team led by Dr. Charlene Ronquillo from the University of British Columbia, Okanagan, and in collaboration with Western University. We're excited to be here to present our current progress on a scoping review entitled Patient Trust in Nurses, Potential AI Integration and Application in Healthcare. Before we kind of get into the meat of the presentation, given our collaboration with Western, where both Natasha and I study, we just wanted to extend our acknowledgement that Western University is located on the traditional lands of the Anishinaabe, the Haudenosaunee, the Lupanuak, and the Attawandaron people, on lands connected with the London Township, the Sombra Treaties of 1796, and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples who we recognize as contemporary stewards of the land and vital contributors to our society. So a little background here, the adoption of artificial intelligence, or otherwise known as AI, in healthcare is motivated by the promise of improved patient care and provider workflows. In a rural context, AI is viewed as one potential part of the solution to ongoing accessibility issues. AI technologies are being rapidly developed for these contexts and are not only supporting healthcare practitioners, for example, with endoscopic capsules for remote diagnostics, but are also becoming increasingly available for patients directly through smartphones and wearable tech, for example, apps that diagnose skin lesions. We know that the development of these technologies is quickly advancing, but with great potential. However, there remains hesitancy among healthcare providers and consumers alike. Establishment of trust in these technologies is paramount as we start to look towards becoming more seamless in their integration within the healthcare system. However, it's not entirely sure how trustworthiness in AI can be established. Public opinion polls have consistently shown that nurses are among some of the most trusted professions, which may give us some insights. So what is it about nursing that warrants this trust? And what can we learn about the trustworthiness in nurses that can help support the safe and ethical adoption of AI? So we have been conducting a scoping review using the Joanna Briggs Institute methodology. In keeping with our research questions, which we'll discuss shortly, our overarching goals of the scoping review is to provide an overview of different approaches and conceptualizations of trust within the nurse-patient relationship, as well as identify any gaps within the literature in this domain. We'll use the scoping review of the nursing literature as a means to compare the conceptualization and aspects of trust that we find in a more computational perspective, as outlined by an article by Liu et al. That we'll discuss shortly as well. So for our scoping review, we developed two research questions. The first being, what features, dimensions, and/or actions support building, maintaining, and reestablishing trust in nurses as perceived by patients? And the second being, what can we learn from patient trust in nurses that can contribute to developing trustworthy AI? As you can see here, we have some inclusion and exclusion criteria. The inclusion criteria being things were written in English, articles were peer-reviewed and related to developing, maintaining, or breaking trust between nurses and patient. And this was primarily centralized patient perspectives, but also included proxies such as family and caregivers. And then our exclusion criteria were concepts of trust that were not related to the patient perspective. So for example, articles that examined from the nurses' perspectives, or perhaps sometimes among nurses and other healthcare professionals. I should note that we didn't limit by date, and we were inclusive of all types of nurses. However, we did exclude midwifery. They did come up in our initial survey, but because they are a distinct practice, we did exclude them. And as you can see here, we began our initial database search using CINAHL, Embase, Medline, and PsycInfo. We used the key terms derivatives of the word nurse, trust, patients, and healthcare, and we obtained a little over 2,500 articles, and we've been kind of working through our scoping review. We are now at the data extraction phase with the remaining 39 articles.
So as Olivia mentioned earlier, we utilize the paper authored by Liu et al. As the foundational framework for extracting data in our analysis. This article presents 6 of the most crucial dimensions in achieving human trust in artificial intelligence from a technical computational perspective. For our data extraction and analysis, we have been mapping our findings from our scoping review articles on how nurses develop, maintain, and sometimes even break trust with patients to these 6 themes. So the 6 crucial dimensions outlined in the article include safety and robustness, non-discrimination and fairness, explainability, privacy, auditability and accountability, and environmental well-being. So I'll provide a quick overview of kind of what each of these themes entail. So safety and robustness looks at AI systems that should be strong and secure. So AI systems should be able to handle variation and disturbances such as unexpected changes or errors within the input data while maintaining high levels of accuracy. So essentially, it should be able to function without making mistakes. Non-discrimination and fairness looks at AI systems that are expected to avoid unfair bias towards groups or individuals and is expected to make fair decisions for everyone. Explainability refers to AI systems that allow stakeholders to comprehend how choices and decisions are made using a language that is easy to understand. Privacy involves the expectation that AI systems securely store the personal and sensitive information in a way to eliminate data breaches. Auditability calls for AI systems to undergo evaluations by third-party groups, while accountability establishes mechanisms to identify who or what is responsible when technology falls short of expectations or leads to negative consequences. So essentially, auditability ensures accountability. And lastly, with environmental well-being, given the development and deployment of AI systems, it does place a substantial burden on power sources. So environmental well-being centers on promoting AI systems that are both sustainable and eco-friendly. So as mentioned earlier, we are currently extracting data from the 39 articles included in our scoping review. And this includes gathering data on the paper characteristics, patient population demographics, and conceptualization of trust as described in the articles. Next, we will look at examining computational trust themes and link any conceptualizations and aspects of trust from these articles to the framework developed by Liu et al. On computational trustworthiness of AI. So to outline some early findings, we've shared data regarding the countries and publication years included in our review. So notably, there is a higher concentration of studies conducted in the USA, and publication dates range from 1994 to 2022. It's interesting to observe the notable increase in articles published on trust in nurses after the onset of the COVID-19 pandemic. So during this stage, again, we just wanted to highlight some informal impressions drawn from the literature. So there exists a multitude of contexts for studying trust, with a notable prevalence in critical care areas such as neonatology and pediatrics, psychiatry, end-of-life care, and within vulnerable communities such as immigrants and nursing home residents. We've also found there are numerous articles focusing on trust development among specific racial or ethnic groups. And our preliminary reviews and discussions indicate that we are encountering diverse conceptualizations and measurements of trust. So 2 additional considerations we've observed include the various types of nurses dependent on jurisdiction and licensing who must establish patient trust, as well as the implications of COVID-19 pandemic on trust, again, noting that increase in publications since 2020. So overall, we do anticipate that these varied conceptualizations may not align perfectly with our analytic framework of trustworthiness on computational perspectives, but we do believe Liu et al.'s framework will still be valuable in structuring our analysis. So far, to our surprise, we haven't seen too much on trust in like rural healthcare and nursing, but we can assume it would be similar with some of those vulnerable communities that don't have a lot of access. So focusing on how can we maintain that trust, knowing that AI is going to be integrated everywhere, can help improve that patient experience and AI integration in the future. So thank you again for listening to our presentation, and I'll open up the board for any questions.
Thanks very much. Are there any questions? So here's one from Cherise. How do you define AI? Would an automated appointment reminder phone call be considered AI? And thanks for that question, Cherise. I was mulling something similar over in my own mind as well. What really is AI? And how does it work for the uninitiated like me?
So yeah, AI, I would say, would be a little more than like reminder appointments with phones. So it's going to be the use of like data and analyzing a high amount of data to kind of make decisions. So like would not necessarily be seen for reminders, but for like a patient involvement, if they are communicating with providers on their phone and they've inputted a lot of data of like their vitals, their symptoms, that kind of stuff, it can kind of analyze that overarching data of health information received to highlight concerns of potential factors that may be affecting or causing that illness that that patient is experiencing, to provide, you know, maybe further guidance of we can monitor at home, or no, you do need to be seen by someone. That would be more of kind of how we're defining AI, if that answers your question. I know sometimes it's hard to explain AI exactly because there's lots of understandings of it.
Yeah, I suppose another thing just to add on to Natasha, artificial intelligence is kind of like a vague term used. And I think if you ask somebody who has like the technical side, they would say it's kind of broadly speaking to anything that can artificially be intelligent, naturally intelligent being animals. With that said, when we kind of get more into the literature and you learn about machine learning and deep learning and that sort of thing, that's more specific to what we now know or what we hear, I suppose. Things like ChatGPT and such. Those are technologies that we use. These are things that are generating knowledge from data, as Natasha was explaining there, in ways that are not exactly, but to mimic neurons and neural networks and things like that. But yes, there is a differentiation between these different words.
And here's one from Tracy. What are you most excited about in this area?
In this area? Yeah, I mean, there's so much potential. I think one thing I'm particularly interested in, and we kind of talk about this here in our scoping review, taking a more patient-centric perspective, is the democratization of these technologies, ideally in the future, and kind of enabling patients, giving them access to these things to really participate a little bit more in their health. And we start to see that in wearable tech. People are electively choosing to wear watches and download apps and things like that to be engaged. And I think that's something we can leverage, obviously in a safe way, and an informed way. I'm not saying it's always best having Google or Apple having your data, but there are certainly some really exciting possibilities there to engage our patients in health.
And I guess for me, kind of similar to what Olivia has mentioned, but I actually work as a virtual care nurse currently. So I am actively working with those AI systems through data collection and those head-to-toe assessment questionnaires. And then the system's kind of flagging patient concerns and kind of recommending steps of where they should go, you know, whether it's calling me as their remote care provider? Should they be going to their local hospital? And we're doing this currently within Southwestern Ontario. So we are providing this service to a lot of the rural communities in our areas that don't have access to the specialized service of our lung surgery patients. So I'm really excited to see as this continues to grow and expand, the potential benefit it does have, because I know people are very intimidated by the service when I first introduce it to them. But by the end, they are quite intrigued and they really are finding it's beneficial. And we're starting to see already the early stages of the decreased burden on our healthcare system with emerge visits and readmission rates by catching things earlier and taking that more proactive approach to healthcare.
Thanks very much. And your response there, Natasha, made me think of some of the work that's happening in BC using remote care. And it comes down to the trust piece. So some of the presentations earlier this morning, it was very clear that trust really came from relationships. And with a lot of the virtual care offerings in BC, they're also based on relationships with those providers also actually going out and visiting those communities at a personal level and developing relationships. And then finding that virtual care is so much more informative and good for everybody. Your experiences of that trust building being like in that area?
I would say it is quite similar with some of that, especially with our patient population. Like a lot of our patients are between 60 and kind of high 80s. So again, not necessarily familiar with technology to begin with and kind of have maybe a basic understanding of kind of using their phone or, FaceTiming with family. So a lot of them tend to be very hesitant. And so I kind of talk them through everything and walk them through the process. And I unfortunately don't have the ability to actually go to their homes physically, but I feel we've kind of overcome that by doing frequent phone calls. So we do still have that AI portion that is analyzing that data, catching those things that, are trending quicker, but we still have that component of communication and like talking to a human, which I think makes that trust easier in this system because they do know there's someone kind of in the background, kind of keeping an eye and there to answer those questions that they may not be able to directly, ask otherwise.
Very good. So do we have any other questions from anyone before we thank Natasha and Olivia for a lovely presentation? And I really look forward to seeing what happens next. My experience of AI is auto spell in my phone and it drives me nuts. Saying things like, I'm now calling it AU, which is artificial unintelligence. Good. Well, thank you very much. And if anyone wants to connect with you, they can do so. So we're now going to move on to our next presentation. And Rainer, I see you online, and the floor is all yours. And you're going to be talking about miscarriage diagnosis and such another important area around communication and rural. So the floor is all yours.
Thank you so much for having me, and thank you for joining me today for this research presentation on conveying miscarriage diagnosis to patients. This particular presentation takes a focus on the routine prenatal ultrasound scan appointment. And so it's largely applicable to ultrasound technicians performing that ultrasound scan. However, it is also relevant to other healthcare providers and decision makers, particularly healthcare providers using point of care ultrasound. So to provide a bit of context, approximately 15 to 25% of clinical pregnancies end in miscarriage, and in BC, that is more than 15,000 miscarriages occurring annually. Miscarriages are commonly referred to either spontaneous or missed miscarriages, and for the purpose of this presentation, I'll just define what miscarriage is. It's commonly diagnosed at a routine prenatal ultrasound scan when no heartbeat is detected. And this can be particularly shocking to patients and partners because of the lack of symptoms that commonly accompany other miscarriages. And both, whether it's spontaneous or miscarriages, often result in mental health implications. So the findings from this research that we'll talk about today is from a larger study on miscarriage recovery in BC, which took a hybrid patient-oriented and community-engaged approach, and it involved policy analysis of prenatal care guidelines, as well as policy analysis of bereavement leave legislation, interviews with 27 people with lived experience of miscarriage, and then a discovery action dialogue. Participation with the interviews included people from across our regional health authorities, and this also included urban, rural, and remote geographical settings. Patients reported between 1 and 4 miscarriages, and then 62% of the people that participated in the interviews had experiences with miscarriages, and 27% also experienced other types of pregnancy or baby loss. Again, for the purpose of this presentation, I'm just going to narrow down into 3 select findings. So the first is that while in BC we have prenatal care guidelines for stillbirth, guidelines for miscarriage and other forms of early pregnancy loss are not fully developed yet. An example of this is that while an evaluation and care checklist exists for stillbirth, it doesn't exist for miscarriage. And similarly, within the standards for obstetrical ultrasound assessment, there is no section on miscarriage presently, so some opportunities there. And when we look at this first finding, it can be a place where we can begin to understand patient experiences with the second finding, where they're commonly reporting a lack of or complete absence of follow-up care following a miscarriage. And then when we drill down further with the patients who had experiences with miscarriage, learning about the miscarriage during the routine prenatal ultrasound scan was often described as a devastating, traumatizing, or shocking experience. And patients went on to emphasize the need for compassionate care and communication from ultrasound technicians and the other healthcare providers supporting them during this time. So this resulted in 6 key recommendations around how we can support patients and partners when communicating a miscarriage diagnosis, particularly during that routine prenatal care ultrasound. All of these coming from the experiences of patients, and what they shared was the most difficult part of learning about that information. So first and foremost, there's a huge opportunity to provide trauma-informed training to all ultrasound technicians and other healthcare providers who convey miscarriage diagnoses to patients and their partners. The second one here, I know it might be a little bit controversial for some providers because currently the standard is that only the patient is present for the first part of the ultrasound scan, and then the partner can join later on. Patients who experienced a miscarriage diagnosis on their own often describe that this experience was made worse by not having their partner there when they received the initial news. So it's an opportunity to reevaluate this current practice. And then looking at how we can support connecting our patients when they're in clinic receiving this information with an on-site radiologist, physician, or midwife. This particular finding came because some patients were actually sent away out of the clinic without any information. And this can be particularly upsetting for somebody because they know something's wrong when they're not shown the ultrasound screen, they're not given a photo, or the ultrasound technician starts acting quite unusual. And so they already know that there's some bad news coming in their way. But in some cases of patients, they're just told to go call their doctor. And this can leave patients in a very distressing state while they wait to connect with a doctor or midwife. And in some cases with patients, it was days before they were able to get in with their healthcare provider to receive the formal diagnosis. When we provide the opportunity to connect the patient and partner with somebody on site to receive that information versus sending them away, there's also a great benefit in providing a private room for them to be in to receive this information. Again, coming from patients themselves, being put back into the waiting room after they're waiting for the formal diagnosis, but knowing that the news isn't good is particularly traumatizing, especially when it is a clinic that does a lot of prenatal ultrasounds. Some patients shared that, you know, being seated amongst a lot of pregnant women was more traumatizing for them after learning the loss of their pregnancy. And so if we can provide a space for them to be in to receive that information, we're just providing a safer space within those clinics or hospitals. And then when we provide that space for patients and partners, there's also an opportunity to have a conversation if they would like to receive the ultrasound photo or not. Again, coming from patients in this study, some patients were given a photo and didn't want it, and some wanted a photo and weren't given it. So just remembering that we should never make the assumption on behalf of the patient of if they should or should not receive the scan. For some patients, it will be the only photo they have to remember that pregnancy. And so for some, it is important to receive, and for others, it can be more challenging to receive that. So just remembering to provide choice to patients and partners in that decision. And then this last recommendation, it's just going that extra step in providing compassionate care, and that is initiating a process to cancel the future prenatal appointments that patient might have had. Patients that had to call in and cancel their appointment and explain why they were canceling the appointment found that experience particularly distressing. And when we have an opportunity to provide one or more of these recommendations to come along and support patients and their partner during this very difficult time, we just have the opportunity to make this difficult time a little bit less on the patient. Thank you. I'll pause there for questions.
Thank you very much. Olivia has posted a question, which is actually exactly the same one that was running through my mind, which is about, can you give some background on the partner rule? When I looked at that, I thought, well, that's a silly rule. And you know, why is this the current practice? A very good question from Olivia. But what I'm really liking is that you're challenging it. And you know, this is a very good quality improvement step. So some background there would be very helpful.
Yeah, that's a great question, Olivia. And I have to be honest, I don't know where that rule started from, but very common practice going to a hospital or to a clinic. They will say you're not allowed to have your partner in the room for the first part of the scan. There's different thoughts on why this might have been established. Sometimes it's thought, you know, kind of around the physical safety of the ultrasound technicians is what's been brought up kind of in the past in these conversations. However, I think the risk of you know, an altercation to the ultrasound technician is far less than the risk to a patient going through a challenging situation on their own in those rooms. And I think to your point, David, where it feels fair to challenge this rule is that people actually go to like private ultrasound appointments where both of them are allowed to be present. And so if that can be provided as a private service, I think that there is a great opportunity for us to consider that as a public service also.
And I guess also the question always is ask the patient, what would they, some may not want the partner.
Yeah, absolutely. Some won't want the partner there, particularly if maybe it is a relationship that, you know, if, for example, has an intimate partner violence component. But I think it can also extend beyond just the prenatal ultrasound appointments. When we think about, we're a beautifully diverse country, and even being able to have other support people there, and particularly for people who would like to have like translation support from another support person.
That's great. And here's another question from Tracy. I appreciate the thoughtfulness around the recommendations. Has there been or are there plans to create resources or tools which would, how to establish these in the healthcare centres?
Thank you so much for asking that. So as part of the larger study on miscarriage recovery that this was part of, we've developed a policy brief that's just in the final phases, and that will go out to both the regional health authorities, but all the specialized agencies that are involved in prenatal care, perinatal care, and pregnancy loss in BC. I'm sure this is not a surprise to any of you on the call, but BC has the extra layered challenge that we have a particularly matrix healthcare system. When we look at Alberta, we have one health authority. Here, as we all know, we have many, many. And as much as I think everyone tries to collaborate and work together, we still have a lot of silos to overcome. And so we're really hoping that the policy brief will start to bring people together, because it really took a system approach, identifying, you know, these are the different health authorities and different agencies that could be playing a part, and how do we hopefully start working together in this area. And then we've actually just put in a proposal for a future project that would go towards developing tools and resources for the health authorities also. So fingers crossed on that one.
Bob Woolard has also posted a message. Thanks for the sensitive delineation of issues around pregnancy loss. Often it's passed over as the tragedy it really is. Most parents, when they get a diagnosis of pregnancy, will envisage a lifetime going forward to graduation and beyond. And that is what is lost and worthy of grieving.
Absolutely. I very much agree. And as someone with lived experience of miscarriage, I can definitely share that that is something that continues to impact our life.
So very good. And the other thing you did mention is the growth of point of care ultrasound. And you know, the RCCBC does a lot of point of care ultrasound courses for rural physicians.
Yes, amazing.
I think the ultrasound techs are so much part of the team, but there's not very many of you in rural areas.
Yeah, absolutely. And interestingly, you know, as one patient shared, that when someone has a bad experience in a particular clinic in a rural area, they're actually willing to travel, even if it's a couple hours away, to go to a different clinic during their next pregnancy, because it was too hard to go back to that first one. So there's definitely a lot of challenges for rural and remote locations.
And I think it comes back down to what I'm seeing as a theme of many of today's presentations, is that the relationships are critical.
Yeah, absolutely.
So any other questions for Raina from anybody? And we wish you all the best with this. I think it'd be very nice, as someone suggested, to see how this will be kind of expanded to all the different settings, and so that the compassion becomes part of it all. And, you know, I think we have a kind of, when I look at modern healthcare, there's so much technical intervention that kind of squeezes the empathy and compassion out. We need to keep reminding ourselves how important that is. So great work, Raina. Thank you very much. And
Thank you.
We'll now move on to our next session, which is Taylin and Kaylee, who are our final presenters today. And I'm really interested in school start times that you're talking about. I'm really looking forward to what you have to say. So the floor is all yours. Yes, I should say the virtual floor.
Okay, can everyone see our slides?
We can. That looks great.
So welcome everyone. Thanks to coming to our presentation titled Do School Start Times in British Columbia, Canada Follow Recommendations for Start Times, a scan of publicly available school start times. My name is Taylin Michon, and I completed my Bachelor's of Science in Psychology from UBC Okanagan in 2022. And I'll be co-presenting today with Kaylee Bogart, who is a current third-year undergraduate student, also studying psychology at UBC Okanagan. We'd like to start off with a land acknowledgement. We respectfully acknowledge that we live, work, and play on the traditional, ancestral, and unceded territory of the Syilx Okanagan people, and we are very grateful for the opportunity to work and learn here. As our research also looks at schools across the province, we would also like to acknowledge the traditional territory of other Indigenous peoples in British Columbia. So to start, it is recommended that children aged 5 to 13 years obtain 9 to 11 hours of sleep per night, and youth aged 14 to 17 years obtain 8 to 10 hours of sleep per night. These recommendations are made by the Canadian 24-hour movement guidelines for children and youth. Youth sleep in Canada is poor. About 1/3 of Canadian youth do not meet the sleep recommendations in these guidelines. Later school start times are a recommended strategy to help youth obtain sufficient amounts of sleep. The American Academy of Pediatrics and the American Academy of Sleep Medicine recommends that school start times for middle and high schools is 8:30 a.m. or later, to not only provide an opportunity to adolescents to obtain sufficient amounts of sleep, but also to support adolescent mental health, psychological well-being, and safety. Canada does not have national recommendations for school start times. So our research questions were, what is the average school start time for standard schools in British Columbia? What is the median school start time? And is rurality associated with school start times? For our research method, we used a publicly available list of all schools in British Columbia from the BC Ministry of Education. We conducted web searches to find school websites or school district websites with school start times. And then all school start times were verified by a secondary verifier, and any disagreements were resolved by a third verifier. We then linked schools to the index of remoteness by linking school locations in the school list to community names in the index. The index of remoteness was developed by Statistics Canada to measure proximity to population centers. It is determined by a community's distance to all population centers in a given travel radius, as well as the community's population size. This index is also a continuous measure ranging from 0 to 1, 0 corresponding to the least remote and 1 corresponding to the most remote. We were unable to link about 200 of the schools to the index, so we consulted with a data librarian and data consultant, and they helped us link the last 200 schools. Data analysis was completed in SPSS, and we calculated means, standard deviations, and frequencies to determine the average school start time and the number of schools that met school recommendations. We also completed a Pearson correlation to determine if rurality was associated with school start times. I'm now going to pass it off to Kaylee, and she will discuss the results.
Thank you, Taylin. Moving on to our results. We chose to only include the standard schools in our analyses. There were 1,759 standard schools, which encompassed 90.3% of all schools. We chose to only include the standard schools in our analyses because the alternative schools had significant variation in start times. We were also unable to find many of the start times for the alternative schools. These school start times were included for all grades, kindergarten to grade 12. Next slide. There was a total of 1,759 standard schools. There is missing school data for 206 schools. For these missing school data, we were unable to find the school start times, and they were excluded from our analyses. This left 1,553 standard schools. Numerous schools had multiple start times for different grade levels or programs. We decided to include each start time separately, which resulted in a total of 1,868 individual start times. The average school start time was 8:41 a.m. with a standard deviation of 16 minutes. The median start time was 8:40 a.m. The earliest start time was 7:09 a.m. and the latest start time was 10 a.m. There were 2 schools with a 10 a.m. start time. They were both independent schools. Without the 10 a.m. start times included in the analyses, the average start time and standard deviation were still 8:41 a.m. and standard deviation of 16 minutes. Next slide. So 1,443 of the school start times met the recommendations for school start times. This was 87% of the schools included in the analyses. The red arrow on the slide indicates where 8:30 a.m. falls on the histogram. Next slide. The Pearson correlation results revealed that a higher rurality was negatively associated with school start times. Thus, with increased rurality, school start times were earlier, and with decreased rurality, school start times were lower. This was a weak but significant correlation. Next slide. To contextualize, Vancouver has a rurality index of 0.062, which corresponds to less remote, and Bella Coola has a rurality index of 0.72, which corresponds to more remote. Next slide. Our average start time of 8:41 a.m. contrasts to previous research in the United States and Canada. Previous research in the United States found an average start time of 8:03 a.m. and 8:01 a.m. And previous research in Canada has found an average start time of 8:32 a.m. 87% of the start times in our research met the recommendations for school start times, whereas only 17.7% of the schools in the United States met the recommendations. The median start time found in Canada in previous research was 8:42 a.m., which compares to our median start time of 8:40 a.m. In previous research in the United States, rurality was found to be associated with start time. Higher urbanicity was associated with earlier start times, and non-urban was associated with later start times, which contrasts our finding of rurality being negatively associated with school start times. Next slide. So some strengths for our study include our use of population-based analyses, with only a small amount of data missing, 11.7% of schools. We also analyzed and collected data for all grade levels from kindergarten to grade 12. All extractions were verified. Some limitations for our study include the difficulties to account for schools with multiple start times. Additionally, some schools had updated websites between the initial extraction and the verification. When we encountered this, we chose to include the latest start time. We also relied on website data, which is potentially not the most accurate or up-to-date source. Next slide. In conclusion, the school start times in British Columbia are supportive of the adolescent and childhood sleep recommendations for school start times. British Columbia is a good example for optimal school start times. We will run some additional analyses to determine what factors may have contributed to this success. Furthermore, increased rurality is associated with earlier school start times. Future research is needed to resolve the practical issues pertaining to the implementation of later school start times. Next slide. Here are our references. Thank you for listening. We would like to acknowledge the contributions of Matthew Vistumbar, Stefano Mazzini, the UBC Work Study Program, and the Canadian Institute of Health Research, Sleep Research Consortiums. Please feel free to contact the Slumber Lab for more information. Thank you.
Thank you, Tyler. Haley, are there any questions that anybody has? Very interesting research. So Charisse has a question for you, which is there any link between start time and grade? In other words, were high school start times later compared to elementary schools and things like that? Yeah.
Hi, so good question. So we didn't split between elementary, middle, and high school. A lot of the high schools had different grades, so we ended up splitting based on grade, but we haven't looked at that just yet. We are planning on looking at that in our later analyses. But that's a good question.
The other thing that struck me is that I think you're saying that in rural areas, the schools start a bit earlier. And does that mean rural kids don't sleep so well, or are they all up early because parents have to get to work on farms or travel to work and schools need to start earlier?
That's a great question as well. We will look into further research for the factors pertaining to the start times, although at this time we don't know which.
And I guess the other thing, having grandkids at high school here where I live, their school start time is at 8 officially, but there's an optional for the high school students. Someone can go to a leadership session, which actually starts at 7 a.m. 3 days a week. Are you able to capture those kind of things as well through the webs?
Yeah, so in our analyses, we took the first start time of like class 1, where pretty much every student would have to be in the seat of a class. But we did see on a lot of the websites that they had like block 0 or like extracurricular activities that did start at 7. But because not every student really needed to be at the school at that time, we decided to not include those ones.
Tracy's also asking what's your definition of a standard school? Curious about what the catalyst for the research is.
So a standard school, so compared to the other schools, like an alternate program or distributed learning program, those ones are schools that are online or don't have a typical learning format where students don't need to be in the classroom. So they might meet outside the normal timetable or do it at like a self-paced. And then there was also continuing education, which was for older students, I think over 19. And then the standard schools are just the schools that have the typical format of K to 12 in a public or independent school with a teacher or somewhere where they'd have to be at a certain time.
And the second part of her question, which I'm also curious about, is so what do you hope through this research to be able to achieve? In other words, what are your original goals?
Mm-hmm. So I think one of the main goals was we wanted to compare school start times, because I think previous studies in the US showed that school start times were quite early. I think in one study, if I remember correctly, early school start time was also 7 o'clock, something around there, which is pretty early. And they also wanted to look at sleep, so the factors affecting sleep.
Yeah, I guess so. That is the bottom line here about whether earlier school times disrupt sleep. And I guess you have to then, the next stage in this research is to find a whole bunch of kids in different places and see how long they're sleeping, because I know the other impacts of school sometimes are coming home late from things that have been going on and et cetera, et cetera. So there's a lot of complex things, isn't there? So what's the next steps for you?
I think we're going to look at factors that like facilitate or could be barriers to changing school start times. I know that in a study in the United States, bus schedules was one of the main factors for making school start times later. And then as well as like childcare. So parents who have to go to work at 8 or not 8 or 8:30, if school start times are at 9:30, they may have trouble finding childcare for that extra hour.
Yeah, Great. And another variable, living up in northern BC is, have they plowed the roads in time? So any other questions? Well, thank you very much for your presentation and for joining us. And we've now come to the end of today's Rural Health Exchange. And thank you everybody for coming along. It's been a very interesting session. I've learned a lot from it. It's so nice to see so much research going on, which is actually relevant to the rural context. We still have major health inequities in this province. So I guess with no further ado, is there anything else, Tracy, we need to say before we sign off?
No, that's everything. Thank you so much, Dave, for facilitating today, and to all the presenters and all your wonderful work. Please, for attendees as well as presenters today, you will get a couple emails from me. So we're just looking for some feedback in an evaluation form, as well as look forward to connecting folks with interest about each other's work that was shared today. So look forward to me spamming your inbox. And if you have any questions or need anything at all to do with the BC Rural Health Research Exchange or research affiliated with RCCBC, please do not hesitate to contact us. And thank you again for joining us today.
The rural environment works in networks, and the RCCBC is a network. So if you need to network, you know where we are. And thank you very much. And all the best. And I say, Tracy will reach out to you. These sessions are recorded and they will be made available on the RCCBC website in time. So take care, everybody. Enjoy the rest of your day and keep up the good work. You're doing some really great stuff. And Tracy, thank you so much for making all this happen in the background. Well done.
No problem. Thank you, everyone.
Bye, everybody.